Dr. Amra, we will start now. Yeah, thank you. 4 minutes.
So good morning everyone. I am Dr. Amravisha. I am practicing as a uveitis specialist here in Vadodara, and today I will be presenting a post-febrile storm in the retina, and brainstorming with me through this storm was Madhvi ma'am. So let's get started. This 37-year-old male presented with a sudden loss of vision in both his eyes since the last 2 days. He had a history of high-grade fever 15 days back, which was undiagnosed. After he recovered from this febrile episode, he started developing some dimness of vision in his eyes, and he was diagnosed to have post-febrile retinitis and treated with 3 doses of IV pulse steroid. However, after the 3rd dose of IVMP, his vision dropped dramatically, and when he presented, he had a vision of counting fingers close to face in his right eye and only perception of hand movements in his left eye. So this was the fundus picture at presentation. As you can see, there is extensive involvement of the posterior pole. There are dense exudates radiating from the disc along the vascular arcades. But what is important to note here is that there is predominant involvement of the arterioles rather than a venous pattern. You can appreciate the whitish exudates which are clustered around the disc and the involved arterioles, which is suggestive of an occlusive vasculopathy in addition to an inflammatory pathology. So to confirm this, an angiography was done, which in its early phase again showed predominant involvement of the arterioles. But what is striking here is the presence of large capillary non-perfusion areas, especially involving the macula in both eyes. You can also see the pruning and the irregular filling of the vascular networks, which is again suggestive of an occlusive vasculopathy. In the late phase of angiography, there was extensive leakage from the involved vessels, but we have to note that the capillary non-perfusion areas persist even in the late phase of angiography, which is suggestive that there was an underlying ischemia in addition to the inflammation. OCT again confirmed our findings. There was hyperreflectivity of the inner retinal layers with loss of normal retinal architecture, and there is massive subretinal fluid, which is more likely indicative of a breakdown of blood retinal barrier rather than just plain exudation.
But even now, there is no share.
So, given the predominant involvement of the arteries, an occlusive vasculopathy-like picture and profound ischemia in addition to inflammation, a diagnosis of an occlusive vasculitis became more likely than a post-febrile retinitis, which is more focal, has more exudation in comparison to ischemia, and has a more venous pattern rather than an arteriolar one. Given the poor response to steroids, a systemic workup was done, but all investigations remained non-contributory. So it was time to reassess. We knew that the patient had received 3 doses of IV pulse steroids. He was on oral doxycycline, but there was a worsening of vision. At presentation, given the poor response to steroids, a negative systemic workup, and an atypical clinical course suggestive of an occlusive vasculopathy, there was a strong suspicion of a viral etiology, and IV acyclovir was initiated for 10 days. Subsequently, 48 hours after starting IV acyclovir, oral steroids were reinstated, and after 10 days, we switched to oral valcyclovir. Around the 3rd or 4th day of starting IV acyclovir, the vision recovery was significant, and at 1 month you could see that there was significant reduction in the exudates, more in the right than the left eye. Subretinal fluid had resolved completely. However, the ischemic changes continued to persist. You could see there was significant disc pallor in the left eye. The vision in the right eye was 6/18, and in the left eye it had bounced back to 6/60. So in conclusion, in this case and many often cases of uveitis, a line from Professor Dr. Narsingh Rao is always very relevant, that recognizing when a disease is not behaving as expected is often the key to changing its clinical course. So thank you everyone, and thank you team VRAG.
Very nice case, Amravi. Any comments? Navneet? Post-fever retinitis?
Anything to done to diagnose its post-viral like aqueous strep?
No, sir. When he came, he had complete loss of vision. He was a 37-year-old male being guided by two people into the OP. So, and given most of his systemic investigations had already been done to diagnose his fever, and it was all negative. So, given that there was no other significant etiology, we initiated IV acyclovir, and he showed improvement rapidly within 3 days. So, the suspicion became real that he did have a viral element.
Because post fever itself is a natural course of it shows
Right, sir.
improvement. Mostly after 6-7 days onwards. It
Right,
starts
sir. And
to-
post fever generally responds very well to IVMP. However, he had a vision of around 6/60, 6/12 in his right eye, in fact. And after the third day, his vision dropped and came down to counting fingers and hand movements. So he was definitely showing a very poor response to systemic steroids, that to IVMP. So some infectious element was also present, became more likely in this scenario. Plus the arteriolar involvement and significant ischemia was seen on angiography, which again led more towards an occlusive vasculitis in comparison to just plain post-fever para-infectious type of retinitis.
Anybody in the audience having any comments, questions, please feel free. Any role of oral VRAG acyclovir?
Sir, in this case, I prefer to give IV because the patient had very poor vision right at the start, and IV acyclovir works better for retinitis or at least retinal viral, especially we see in ARN and PRN. So I prefer to use IV instead of oral in this case.
And I might have missed, did you give steroids along with that?
48 hours, he already had received 3
No,
doses.
after
We skipped for 48 hours and then reinstated oral steroids.
Oral steroids.
Oral steroids, yes.
Yep, please. Roll off?
IVT.
He's asking roll of IVT, eh?
I didn't, considering that I thought that it was infectious, I did not try to give IVTA in this case.
Yeah.
And he was responding well by day 3 or 4, so
Cytomegalovirus, can we consider cytomegalovirus?
yeah, sir. So CMV could have been an option, but seeing that it was very significant and a very rapid progression was seen, so it seemed more herpetic than
In the
CMV.
clinical picture was not looking
Patient-
CMV
And the patient was
retinitis.
immunocompetent,
It's
so
more
he was not
the
otherwise.
herpes group of
You said it, the arterial involvement. There is a venous involvement also, right? There is a venous involvement also. Patient has
Yeah, yes, sir,
SRF.
definitely the patient
The
did
patient
have.
has SRF and macular edema.
Yes, sir, but
if there
the
is a predominant arterial involvement, you won't see the macular edema. There's a
Right, sir,
bilateral
but
macular-
maybe it was also because of ischemia leading to that breakdown of blood retinal barrier, because it was massive
See,
when the patient
if
first
you look at the
presented.
clinical pictures, there is a venous torsosity, right? If you go to the fundus picture, there is a venous torsosity. So I would suggest there is an arteriovenous component both together.
Definitely,
So I would
sir.
consider maybe it's a post-viral or it may be a post-febrile, what you say. It's a combined occlusion type of pictures. You see ischemic changes as well as macular edema.
Right, sir, both were there, but the ischemia was much more profound to what we routinely
Is there any
see in-
vasculitis along the venous? Is that you see there any active vasculitis?
On the angiography, late phase did show extensive exudation from the
Sangeet?
veins.
Yeah, one thing these days, like nowadays, we're seeing viral infections without fever also. So just keep in mind, like bilateral presentation, simultaneous, similar picture, acute presentation. You have to keep some kind of infection in mind. That is the thing. One thing that I would like to say. No, we can't be sure which infection until and unless we get the tests done, but sometime we have to keep infection in mind.
Last comment? Then
Yeah, I just wanted to ask you, what was the picture before IVMP, and do you think maybe something could have been done to rule out any active infection before the IVMP in the eye?
I did not have any pre-IVMP pictures, but when he presented, he did have significant subretinal fluid and ischemic changes had already set in. And this was a history of only 2 days. So within 2 days, this retinal ischemia had increased dramatically. So we decided to act quickly and add in.
And how long would you continue the antivirals?
So for the IV was continued for 10 days. By I think day 3 or day 4, the visual recovery was significant, but OCT still showed a lot of subretinal fluid, and we continued it till 10 days, then switched to oral valacyclovir, while of course.
So how long would you continue the oral?
For 6 weeks.
6 weeks.
Yes, sir.
Thank you, Amravi. I think we need to stop.
Just one last question. So in that case, what is your take on how to differentiate clinical viral retinitis versus post-febrile course? In this case, what would be the take-home message?
No, basically, it's a post-febrile retinitis. Only the etiology was a question. So basically, as Navneet mentioned, we would have probably done a PCR or an anti-chamber tap to rule out viral or other etiologies. But as she mentioned, because of the systemic condition of the patient, it was not possible. And a therapeutic trial was given and the patient responded. So empirically, we can say it was a viral etiology.
Even if the PCR results would have, whatever they might have been, I don't think the course of treatment would have changed much.
Thank you. I think we are ready. Dr. Ratnam, ma'am. Yes, ma'am. We can see your slides. We can see your slides, ma'am.
Good morning, Ratinam. Can you hear me?
We can hear you.
Yeah. Okay. Do you see my slides?
Yes, ma'am.
Okay. Very good morning to everyone. I'm very happy to be with you on this Monday, this Sunday morning, to talk on a very, very interesting nature of uveitis as well as cases of uveitis. If you are entering a cataract clinic, there may be a patient with mature cataract and there is no other differential diagnosis and no other treatment other than cataract extraction and IOL. Everything is so clear. And maybe the cataract, immature cataract or mature cataract, or occasionally traumatic or congenital cataract. That is it. No other differential diagnosis at all. If you enter even the retina clinic, if there is a hole and a detachment, it is a rhegmatogenous detachment and you have a defined treatment protocol for that. There is no confusion. Diabetic retinopathy or hypertensive retinopathy, everything is straight on your face. And also, the retina patients will have very well dilated pupil and clear media most of the time if they don't have vitreous hemorrhage, and you will be seeing the pathology with your own eyes, and there is no confusion of differential diagnosis for a rhegmatogenous tardy. But in case of uveitis, it is always a kaleidoscopic picture. The same diagnosis of VKH in an early stage will have different set of clinical signs, whereas the healed VKH will have different set of clinical signs. Early VKH can look like a CSR, whereas late VKH can look like a healed sarcoid. So there will be so many U-turns in uveitis, and there will be so many differential diagnoses, even for a simple case of episcleritis to posterior uveitis. So I am showing 5 interesting cases of where we had to take a U-turn to reach the diagnosis. I am 100% sure that you will enjoy these cases. And this U-turn may take place at the stage of clinical diagnosis, or during the course of the disease, or when we are doing a lab diagnosis, or at the time of outcome. Whatever treatment we are giving, it may not be improving the patient vision. Then we may have to revisit everything and make a U-turn. And the first case I'm showing you is a patient called Tirumurugan. He was 75 years old man with bilateral loss of vision, had an orbital cellulitis in one eye, right eye, and he was very sick. He came in a wheelchair. He was deaf. And the history was defective vision, pain, swelling, redness in right eye because of orbital cellulitis for 10 days, and defective vision in left eye for 2 years. So on examination, vision was just PL in right eye, light perception in right
Excuse
eye.
me, ma'am, we are not
Left
able
eye,
to-
It was doubtful. Yes. You are not able to?
No, now we could see the slide. It's slow, so I think
Okay.
now we can see the slide of the case.
Okay. Can I proceed then?
Yes, ma'am.
Were you hearing me before?
Yes, ma'am. Now it is okay.
Okay. So, to recap, it was a 75-year-old man with orbital cellulitis in right eye. The complaint was defective vision or loss of vision, pain, swelling, redness in right eye for 10 days, and defective vision left eye for 2 years. And vision was light perception in right eye, and vision was doubtful in left eye, and he was stone deaf. So we were not able to elicit any history, and there was obvious lid edema in right eye, a severe chemosis, restricted ocular motility in right eye. Ultrasound showed retinal detachment in left eye, and it was fundus glow was white. And ultrasound showed thickened uvea in right eye and funnel-shaped RD in left eye. And this case was sent to retina clinic also. They confirmed that it is a funnel-shaped RD. Nothing can be done in the left eye. And to continue the treatment for orbital cellulitis. So because it is orbital cellulitis, they wanted to further imaging. So send the patient to CT scan. Surprisingly, CT scan came with mushroom-shaped lesion in both the globes as metastasis. Meanwhile, because the clinical diagnosis was orbital cellulitis, they started antibiotic as usual, IV, and also steroids. But the CT scan changed the whole picture. It showed two dome-shaped mushroom-shaped lesions. They reached the point that it is 75-year-old man, so it could be metastasis. So Orbit Clinic changed its protocol. They wanted to do peripheral smear, other investigations. ESR was raised, but ultrasound abdomen and CT chest was normal. There is no evidence of any for here. So they were very happy just to transfer the case to Uvea Clinic because there was escape route, but orbital cellulitis antibiotic was continued. So when we saw the patient, it was the same ultrasound, uveal thickening and funnel-shaped RD, but because the Uvea Clinic will always give more importance to the history, we dissected the history line by line. Left eye cataract surgery was done 2 years ago, and patient lost vision in left eye. After the surgery, he never regained the vision. Not only that, he had recurrent attacks of headache, tinnitus, deafness, and blurring of vision in both eyes for 2 years. So, one eye surgical trauma and bilateral loss of vision with headache, tinnitus, and deafness is telling you something different. During the time of active inflammation in both eyes, right eye surgery was also undertaken. So, it everything aggravated after surgery. So now you know the deafness is common in sympathetic ophthalmia. CD mass it was not mass, it was only choroidal detachment of sympathetic ophthalmia. It is very surprising, presented as orbital cellulitis, because during the course of sympathetic ophthalmia, other surgical trauma was not able to be controlled by the immune system, so it reacted violently. So we immediately started IV Solumadral. You see the picture, the choroidal thickness settled almost in right eye, and funnel-shaped RD became settling RD with no obvious mass lesion. See this patient, a happy patient, and with a very, very good visual improvement. So it is absolute U-turn, orbital cellulitis to sympathetic ophthalmia. I think you understand the gravity of the situation where the history has to be taken very, very appropriately, and right eye surgery, bilateral loss of vision, deafness, tinnitus, severe headache, bilateral exudative RD is no other diagnosis other than sympathetic ophthalmia, because right eye surgery was also done at the same, the next eye surgery was done during the inflammation. It reacted like orbital cellulitis. But patient went home with useful vision in both eyes. Now we are going to the second case, very important case. This is also a case of a middle-aged elderly lady, non-hypertensive and diabetic, came with severe headache. Obviously, this patient, because she is hypertensive, she will consult only the family doctor first. So she was taken to family doctor. Family doctor saw the fundus. It looked like hemorrhages in the disc. So he thought it is uncontrolled hypertension. So he added antihypertensive. As you know very well, as in the references given, even ACE inhibitor or vasodilator increase the headache. So when he added antihypertensive, she had a much more severe headache and she had giddiness and vomiting. So now the family doctor referred the patient to the neurologist for MRI, as we all do. In MRI, in elderly lady always show some infarct in some places. So a neurologist told vasodilators are enough. But the patient continued to have symptoms. She almost lost vision and giddiness was there. Then patient came to the ophthalmologist. Ophthalmologist only have the tools. So he just examined the disc and the disc had some hemorrhages. But the slit lamp is most important and slit lamp showed the signs of bilateral severe granulomatous uveitis. This slit lamp is not available to family physician or the neurologist. So they were just looking at the disc. Now you know the diagnosis very well. Here is a middle-aged woman with severe headache, which is a systemic prodrome and bilateral acute granulomatous panuveitis with exudative RD in the periphery, which was not noted by the physician because they see direct ophthalmoscope. But when you add everything, it automatically takes you to the diagnosis of VKH. Now other diagnosis. So even though I say that differential diagnosis matter a lot, such a classical case, we come to the diagnosis of VKH. Here the U-turn was hypertensive disease. It was not hypertensive headache, it was VKH headache. We treated with steroids. She was a very happy patient to go home. The third important case is also very interesting. She's a bride going to get married in a week time, and she came with bilateral loss of vision. And it was bilateral exudative RD and hyperemic disc and few macular exudates. And she was using quite a lot of pre-wedding preparation with memetosone steroid ointment. And she had multiple skin cream application as well. She was very tense because of her wedding arrangements. So we obviously thought that it could be either CSR or VKH syndrome. But CSR will not have hyperemic disc. So that is ruled out even though she has used steroids for facial lotions. So we thought it could be VKH. But you will agree with me, the VKH, the most important test is fluorescein angiography, and it neither supported VKH, there is no starry sky pattern, it is just the pooling of the dye in both the eyes. And then we did ultrasound abdomen, which was masquerade. There was a solid lesion here, solid mass lesion. It was not diffuse choroidal thickening. Because of the solid mass, we thought it could be masquerade syndrome or tuberculosis. And now it is only 2 days. Slide is moving on its own. Because of it is only 2 days before wedding, we did CT abdomen, CT chest, and CT brain, and by God's grace, it came as a tubercular etiology, tubercular mediastinal lymphadenopathy. So we started, our PPT was 25, we started 4-drug anti-tubercular drug. In 4 weeks with steroid, everything is solved. So from CSR to VKH, the U-turn was metastasis and finally tuberculosis. And the patient improved very well and had 6-6 vision. This is a very, very interesting patient. A 50-year-old male came with 6-6 vision but defective vision. He was telling defective vision, drusen-like lesions were there. He was given a presbyopic correction. But in 14 days, his vision dropped to 660 and 624. Then he came, it was again the drusen-like picture. We were not able to find out anything. We thought we'll do FFA. He got the appointment on 21st and FFA was done. Preliminary preliminary diagnosis was only drusen and idiopathic. So FFE and ICG was carried out. The earlier picture was absolutely normal, and late picture had hypo lesions followed by hyper lesions. But it was not characteristic of anything, and vision is waxing and waning. So we thought it is not the eye that is the reason, maybe it is the brain. So we did the neuroimaging and also CBC and peripheral smear to rule out any malignant deposits. When we did see the waxing and waning vision, then when we did the neuroimaging, there was a solitary lesion in the occipital lobe. At this time, we didn't want to take any risk. We referred the patient to CMC Vellore for biopsy and diagnosis. They did biopsy, and it was high-grade malignant B-cell lymphoma with ocular malignant cell infiltration looking like drusen. So here the U-turn was drusen to high-grade malignant B-cell lymphoma. This was a very, very classic case, so it was not drusen. And the last case is the most important and interesting case. The first case was a very, very young child, 6-year-old child, absolutely no clue. It is sudden bilateral loss of vision in 2 weeks. Only history was mumps. She suffered from mumps 1 month back. The retina appeared absolutely normal. Even the OCT was not giving any result. And we started steroids, she didn't improve. But the beauty is, the very next case, the same week, came with history of mumps in acute stage. Her patient also had mumps 1 week before, and she came to the ophthalmologist with this picture. This is called cerebriform retinitis. See the cerebral cortex-like lesions, pencil line drawings. And the beauty or importance is this retinal lesion disappear even without treatment within 2 weeks. Then it looks like pale optic disc, where we are likely to diagnose retrobulbar neuritis. The previous case, we thought it is retrobulbar neuritis. Both the cases had mumps. So we refer the literature, and this is reported. Cerebriform retinitis is reported both in abroad as well as in India by Padma Malini. And now mumps outbreak is happening everywhere because the government stopped giving vaccination to mumps. They are giving only measles and rubella. So there are thousands of children suffering from mumps in Tamil Nadu, and I am spreading the news to you also. Be aware that mumps cases can come with mumps retinitis, cerebriform retinitis, and there is no way you can help the patient. The patient will go for no PL in both eyes. So here the U-turn is retrobulbar neuritis to mumps retinitis. So I think this is an eye-opening case. We all should be very careful because they go for no PL in both eyes. And there is no treatment also. We are stressing our government to include mumps in the vaccination program. Thank you so much. If you have any questions, I'll be too happy to answer.
Thank you, ma'am. Wonderful cases of bilateral exudative detachments. Audience, any questions first, and then maybe we'll have a discussion. So if you have any questions for ma'am, yes, Rekha.
If you pick up mumps in this acute stage, does it help? Can we treat at that point of time, and is the visual recovery possible?
और जहाँ तक क्योंकि मैं न्यूमरोलॉजिस्ट हूँ तो
Can you repeat the question? It is not.
Ma'am, if you pick up the case at this point when you have the inflammation on the retina in the mumps case, treating the child with the IVMP, does it will help?
Literature says hyperbaric oxygen will help to some extent. So in one of our patients, we tried hyperbaric oxygen. Vision improved from PL to 3/60. Because we don't have antiviral for mumps, the prognosis is very, very bad. Only thing we have to inform the government to include mumps vaccination program again to make it compulsory. Now it is totally aborted.
Do you give steroids also, or it's just hyperbaric oxygen?
No. We gave steroid. We gave even IV salmeterol. We tried our level best to give everything to this child. We gave IV salmeterol. We gave hyperbaric oxygen. We gave TST. Nothing worked. So far, I have 5 cases in 6 months. So we were very much upset with these cases, but nothing. Only one patient luckily had one eye involvement. 6 in other eye. All 4 patients bilateral loss of vision.
Yes.
Good morning, everyone. Good morning.
morning, Dr. Ratnam. This is Dr. Bhavik here. So, ma'am, is this an antibody-mediated reaction? What we see in the eye?
Probably we think so because and also we should recognize that we don't have antiviral.
So, a question to Dr. G.
When we give specific antiviral and when it is not
My next question was any role of plasmapheresis here? What can we do for such patients? I understand prevention or prophylaxis.
15 days of systemic infection.
So, ma'am, we have a rheumatologist.
After 15 days of systemic infection.
Yeah, we have a rheumatologist, Dr. G. Would like his comments on that.
Sir, mostly these infections are usually cell-mediated, not antibody-mediated, because antibody formation needs time. Don't touch. And if the patient has only first infection, then it will take more or less 2 to 3 weeks to the plasma cells and memory cells to form. So all the infections, just like in the Amarvi, Dr. Amarvi presented the case, they are usually cell-mediated, and virus can directly be cytotoxic, and they can directly damage the cells and the retina. So in these cases, usually we will see that all the drugs that are usually working on the T cells, they are working like cyclosporine, tacrolimus. Why these are these drugs which are more working in uvea and retina? The basis of this, because they are cell-mediated toxicity and not the antibody-mediated toxicity. So rituximab is not working in that. Thank you so much.
Any other questions?
Good morning, Dr. Ratnam. Is it role of antivirals?
Good morning.
Good morning, Dr. Ratnam. This is regarding the other bride's case. There was a mention that facial bleach could be the cause for VK, so I was surprised to hear that association. Is there a link between cosmetic treatment and VKH? Especially facial bleach, which is actually very common, many people undergo, so I was concerned.
No. What she said, because she was using that, the differential diagnosis could have been CSR, not VKH.
No, VKH, it was VKH.
So it turned out to be VKH, but just because
it was a TB case, Dr. Ratnam, I specifically saw VKH and facial bleach.
Yeah, the clinical picture was bilateral exudative RD. So people thought that, we thought that because she was using steroid, our first differential diagnosis for CSR because of steroid, because the first day it was only bilateral exudative RDs. 4 days it evolved. So the second day it was looking like VKH because the exudative RD became big. Then only we did FFA, and FFA ruled out VKH. Then ultrasound showed the solid mass. So there is no role here for steroid at all because it's only the application. How the diagnosis kept on changing like U-turns, 4 U-turns that change. Under the stress of that time, because she is going to get married in 4 days, you have to make a right diagnosis, and we were worried that it should not be metastasis because it was a solid lesion, but luckily CT picked up TB.
So I think ma'am is emphasizing that we get carried away by the history also, and they become biased because she was using steroids
and the stress and everything.
It's CSR, then we say okay, it's headache, tinnitus, we go to VKH, and then we take a U-turn and come to TB diagnosis.
Recently I saw 2 similar cases of exudative RD. Both the patients had headache, they went to neurologist, they did an MRI, infarcts were seen, and so they were treating in that line, antihypertensives and everything. But the radiologist missed the exudative RD which was there in the MRI. So I think we are thinking and treating in silos where the neurologist doesn't hold. And the ophthalmologist also mentioned RD, but then it was not linked to VKH. I think we should focus on the incidence. It is quite possible that if we have RD, then we have to first rule out VKH. And the response to steroid is very good, and the treatment should be better.
I think ma'am has very nicely emphasized the role of imaging in uveitis cases. It's not just the history or the clinical picture, but imaging plays a very, very important role in coming to a diagnosis in such cases of uveitis which are probably masculinous. Any other questions? Yeah.
As ma'am has mentioned, there is no treatment available for mumps. So, can sir suggest any alternative medicines depending upon the etiology, as he has suggested? It's a cell-mediated toxicity. What all can be given?
So it is because of the viral damage, then we don't have anything. Because the recyclovir, these are the medicines which work only for 3 viruses in the herpes zoster family, this family. So we don't have any other treatment. So if any more antiviral drugs, we have to search if they can work on this, like for COVID we are using, or for flu we are using pozotamivir. Such any antiviral can work on that, we have to see.
Nice cases, madam. Excellent cases you have presented, and you have very nicely highlighted that you should not rest with one presumed diagnosis. I think it's very nice to go to the bottom of the case and find out what exactly. I mean, had you been, treated the patient with the first diagnosis you had, then it would have been a wrong thing. So, maybe for the benefit of the young people here, that you should definitely, if something doesn't fit, you should try and go to the bottom of the case to find out the correct diagnosis. I really enjoyed your cases, madam. Thank you.
So we are lucky. I mean, even Amravi's
Thank you so
presentation and ma'am's presentation, you have cases which have not responded to the initial line of treatment, and that has made you think twice. So this is uveitis. I mean, you have to, as Dhanushi says, you have to go to the depth of the disease and find the etiology. Navneet, last comment?
Yeah, truly means that's the interesting part of uveitis. You have to go to the depth. Very interesting cases. Thanks a lot. I think we move to it.
Thank you very much, ma'am, for the excellent presentation.
Thank you.
And on behalf of the Vitreo Retina Association of Gujarat, we would like to give you a memento, and on our behalf, I would request Dr. Madhvi to receive the memento, which we would be sending it to you later, ma'am. So Dr. Madhvi will receive the memento on your behalf.
Thank you. Okay.
Dr. Sangeet
Thank you,
is
Dr. Madhavi.
presenting.
Thank you. Thank you so much.
Thank you, ma'am.
Thank you.
So we now move on to the next presentation. Kushal.
Now I invite Dr. Vaibhavi Notiswala for her talk on the Great Masquerade, severe HLA-B27 associated panuveitis mimicking fulminant endophthalmitis.
Good morning, everyone. Myself, Dr. Vaibhavi Notiswala. I'll be sharing the Great Masquerade, severe HLA-B27 associated panuveitis mimicking fulminant endophthalmitis. So, while following the standard endophthalmitis protocol is life-saving, a small pause in select cases can prevent misdiagnosis. What we are trained to do. When such patient comes into our OPD with hand movement, PLPR, anterior segment involvement, hypopyon, and dense vitritis, we are taught to go for vitreous tap, IOAB, and emergency vitrectomy if needed, because delay in such cases, especially in periphery centers, usually equals vision loss. So we treated case 1 and 2 accordingly. Patient were lost to follow-up. We did what we were supposed to do. But what if it's not an infection? Because there was no history of surgery, trauma, no infective foci in the body. We screened both the cases thoroughly. Only positive history was viral fever 2 weeks back. Something felt off, but I didn't give me time to think. Then came the case number 3 and 4. I didn't wanted to lose this patient to a disease. I screened them thoroughly. This time, luckily what happened was both the patient came on the same day. And the fourth case lead to this diagnosis, as he was a young male and he represented with dense vitritis, thick AC fibrin mimicking endophthalmitis. History, same history, 2 weeks back fever. And the other case was 65-year female who has the same presentation. The female we started with intravenous, antibiotics, and we screened the female. On the 3rd day, we started oral steroids, and within 72 hours, she came with 6-12 vision, and there was dramatic response to the steroids, and it felt like this is certainly not endophthalmitis. And as I told you that both the patients were in my follow-up only, I screened the 4th case for HLB27. He came positive, and simultaneously I went for HLB27 in this case also. So the pattern recognition was seen in case 3 and 4, HLB27 positive. The female was diagnosed with ankylosing spondylitis by rheumatologist. Steroid saved the vision and identified the systemic disease also. But reality check was there only. The 5th patient which came, she was HLB27 negative. She found to be positive for E. coli in urine culture. We treated as endophthalmitis, but it had poor visual outcome. So the core conflict is, if in infection we delay, it will also lead to blindness, and same goes for inflammation. The decision has to be made at right time. So what we propose is, in case of suspected endophthalmitis, if we have high risk infections like any positive history suggestive of post-op or post-injection endophthalmitis, penetrating trauma, go for typical case, the pathway 1. In suspicious inflammation where we have viral fever, as in our cases, you can go for a pause. On day 1, I suggest the thorough culture of blood culture, urine culture, and along with that basic uveitic workup as well. We started intravenous antibiotics for 2 days. Look for the routine follow-up in 48 hours. If it's worsening, surely go for TAP and IUAB, but it's not, start systemic steroids. So severe uveitis can mimic endophthalmitis. Viral fever was critical trigger for HLB27 in our case reports. HLB27 presents beyond simple anterior uveitis, and diagnosis pause can prevent the massive overtreatment. Thank you, everyone.
Thank you, Vaibhavi. I think very interesting cases. Dr. Jeet, all yours.
They were good cases. I would like not to comment anything because we don't have that eyes. Always we have to depend on ophthalmologists, what they are seeing. We just modulate the treatment. So one thing that I want to add is that anytime when you are suspecting infections and you want to wait for the steroids, you can still go for NSAIDs, because NSAIDs are safer. And one thing like we usually very miss, like why should NSAIDs, but they are also going to control the prostaglandin inflammation. So safely we can go like higher doses of NSAIDs like indomethacin 75 2 times a day or 3 times a day. Etoricoxib also we can give. While you wait for 1 to 2 days, you can still hold the inflammation.
So do you think the NSAIDs have a good effect in the uveitis part?
Yes, sir. So as a rheumatologist,
usually the uveitis do not use much of NSAIDs.
Yes, sir.
So straight away use steroids or immunosuppressants. So
that was the thing that I want to comment, because we usually use very low dose steroids. I usually talk with all the respected ophthalmologists who send patients to us. Low dose steroids also help in uveitis. Like we use 20 milligram, 10 milligram steroids, but along with that we start methotrexate, sulfasalazine, tofacitinib, and NSAIDs like etoricoxib. So they all together help us to decrease the dose of steroids and early taper of steroids. And we have seen that with these low dose steroids also, patients usually improve a lot.
So particularly for HLA-B27 associated cases,
Yes, sir.
What would you recommend? Like you recommend starting with NSAIDs and then wait for the diagnosis and then give steroids?
No, sir. In these cases, like she has put a comment, okay, whenever you have to think for infection, you can wait. So in those cases, you can start with NSAIDs, but in all other cases, you have to give steroids. But in steroid also, we have very less data and very gray zones. So low dose steroids in all our rheumatological diseases, now we have low dose steroids. In myositis, vasculitis, before we were giving 1 gram steroids in all the patients. Now we have moved to 500 milligram, 250 milligram. In oral steroids also, we have shifted to 0.5 milligram per kg per day.
That's because you are supplementing it with the non-steroidal drugs.
Yes, sir. And immunosuppressive steroid sparing agents also.
Tyrosine kinase inhibitors and all. Dhruv, I think you had a question.
I just wanted to ask, is HLA-B27 positive uveitis that common in elderly individuals, say 50, 65, 70, 80 years old? Because most of the common presentations do not include that much of a vitritis, more of an anterior and a spillover intermediate uveitis, and in younger population, unilateral, as compared to a 65 or a 70-year-old gentleman presenting with HLA uveitis on the first visit.
So I had gone through the similar cases which was reported. In that it was mentioned that 17% of the cases represent with posterior involvement. And there are case studies, and I would also like to mention Dr. Ashok Kumar's study that he had a case where the patient didn't responded to topical or oral steroid. They went for methotrexate and he had idiosyncrasy reaction to that also. And for keeping endophthalmitis in mind, they went for diagnostic and therapeutic vitrectomy, right? And then they found that patient presented with papillitis, and for that they gave Osirodex. So it can represent as papillitis as well, and they have treated that also.
So thank you. I think there's lack of time, but I think we have learned something new from Dr. Jeet, and I think we all need to learn that this is a good suggestion that while we are waiting, NSAIDs, high dose and low steroids. I think these are two new things which us uveitis will probably learn when we go back home. We'll come to your questions definitely. Let us just first finish the presentations.
Thank you, sir. So I would like to invite next speaker, Dr. Vishaka Jain, for the talk on a rare case of unilateral VKH. Meanwhile, I would also request the next speaker to be ready with their talk. Thank you.
Good morning, everyone. I'm Dr. Vishaka Jain from MNGI Institute, Ahmedabad. I am presenting a case of unilateral VKH. VKH is a multisystemic inflammatory autoimmune disorder that is characterized by panuveitis with iridocyclitis, serous retinal detachment, diffuse choroidal swelling, and optic disc hyperemia. It may be associated with neurologic and cutaneous manifestations. It has 4 stages: prodromal stage, acute uveitis, convalescent, and chronic recurrent uveitis. The ocular manifestations are typically bilateral, but an asymmetric severity is usually present. There are few reports on unilateral VKH disease, and some of them are delayed forms of bilateral diseases. Here we describe a unilateral case of VKH disease. A previously healthy 48-year male patient presented with complaint of painless diminution of vision in right eye since 1 week, which was not associated with any redness, watering, or photophobia. There was no history of any penetrating trauma or intraocular surgery. No history of joint pain, any chronic systemic condition like TB or syphilis, and no history of any similar attacks in past. Ocular examination shows right eye vision was counting finger 4 meters and left eye was 6'6". On anterior segment examination, right eye shows RAPD and rest anterior segment was normal. In left eye, anterior segment was normal. Fundus of right eye showed hyperemic disc with serous retinal detachment along superior and inferior arcade, and left eye was normal. We did investigations. First was OCT. OCT showed bacillary layer detachment with neurosensory detachment with RP undulations and subretinal septa forming multilobular cystoid spaces. This is the video of OCT of right eye, which showed septa, multiple fibrous septa with elevation and fluid. It is typical of weakage, while left eye it has normal foveal contour. On USG, there was choroidal thickening representing acute phase of disease, and there was a smooth dome-shaped, highly reflective retinal membrane, which is suggestive of serous retinal detachment. And then we did fundus fluorescent angiography, which showed a typical picture of VKH. In early phase, it showed choroidal hypofluorescence followed by pinpoint leakages. And then in late stage, there was a leakage and pooling of dye, which showed serous retinal detachment. And FFA of left eye was normal. We did lab investigations, which were all normal. The DD could be CSCR, sympathetic ophthalmitis, and posterior scleritis. Treatment we gave was we started patient with oral prednisolone for 1 week, and after 1 week patient was prescribed tablet methotrexate 15 mg once a week along with the tablet folic acid, and steroid was then tapered. After 1 week of steroid course, the visual acuity of right eye was improved to 6/36 and the lesions also regressed, and after 3 weeks, the visual acuity reached 6/9 and OCT was absolutely normal. This is the fundus picture before treatment, which shows localized serous detachment and hyperemic disc, and this is a red-free photo of the fundus. And after treatment, the lesions regressed and the RP alteration was present. This OCT was before treatment and after treatment. Thank you.
Thank you, Vishaka. I think it's a very common thing that we see, particularly in India, unilateral VKH. It's not VKH, it's mainly the Harada's disease, which is more commonly seen. Comments from Navneet, Dhanashri.
Posterior scleritis, because VKH is a described term for a bilateral disease until unless ICG is done and it shows some subtle changes in the other eye, because ICG was not done in this case. More involvement only of the one eye with bacillary layer detachment and exudative kind of detachment. It could be, I think, just a posterior scleritis.
So I think ICG is not available in majority of the institutions, and our corollary to that, I think a very good investigation is the EDI, the enhanced depth imaging. I think that is a very important, not only a diagnostic but also a follow-up. And it is an excellent tool on your response to treatment, and also it gives you an early clue that that's going to be a recurrence. Usually patients present to us on follow-ups, and if you see that the EDI, the choroidal thickness is again increasing, he is going to develop an attack. So this is a very important tool. You surely do not need ICG, but I think EDI is a must for VKH.
But that's why if the other eye EDI been done, choroidal thickness
they would have shown thickness,
or in sonography thickness is seen. So then we can label it as unilateral VKH, but otherwise I think
it's Harada's, I think, not full-blown VKH.
Or maybe posterior scleritis.
One alternate is, now that we have newer OCT machines, we have integrated OCT angio. OCT angio is a very good investigation, very similar. We'll get similar hypo dots on OCT angio as we get in ICG. So if you have a unilateral case and you have to rule out if the other eye has involvement or not, in the other eye, we can get an OCT angio to look for those hypo spots.
I agree with you. We did this study a few years back, OCT angio in VKH. We saw that hypo and then later with treatment they improved. But it was very difficult to differentiate whether it's just because of VKH, because a lot of entities they present
in
similar.
acute where there is exudative RD, then it is not reliable. So when the RD has settled, then for detecting the early recurrences, and in this case where there is a unilateral presentation, you want to see subclinical other eye involvement where there is no edema, there OCT angio will play a role.
Tanushree, comments? Unilateral VKH cases. I think we see more in younger age groups. That's fairly common, even younger patients, even pediatric age groups. We see a lot of unilateral pediatric patients presenting as unilateral Harada's disease.
No, I agree with you. I'm not a uveitis specialist, but I think there can be sequential involvement of the other eye.
Yes.
And if you have a follow-up of this case, I don't know how much follow-up you have.
Ma'am, we did follow up for almost 2 months, but there was no involvement of the other eye. Involved eyes was also improving.
And also because you have treated the patient also, so that is also one thing. But supposing the patient doesn't receive any treatment, there is a possibility the other eye may get involved down the line. So I think a good long follow-up also is important. But as you said, and as whatever discussion was going on, it's important to note whether the other eye shows any signs of subclinical involvement.
And also it is important to keep treating these patients for long. Even after they resolve, you need to give them long-term immunosuppressants. And you have to start the immunosuppressants early. So along with your steroids, it's been shown by literature, if you start immunosuppressive along with steroids, continue the immunosuppression for a longer time, then there are lesser chances of recurrences.
Two things. One is OCT2 features. One is the seeing the cells in the posterior vitreous and the type of undulation what you see in the VKH. That helps in differentiating between the posterior scleritis and VKH.
Thank you.
Thank you.
Move on to the next presentation.
Dr. Aditya will be presenting ahead because he has some connectivity issues. So I now invite Dr. Aditya. He will be talking on Ozurdex in various case scenarios. He is joining us virtually because of some emergency. He could not be with us today. Dr. Aditya. You are not audible.
Thank you for allowing me to join virtually. So without further ado, let me just go on to. So I've just picked, in the interest of time, I've only picked 2 or 3 cases. I hope to have a fruitful discussion because the continued debate of anti-VEGF first versus steroid first is something that can be addressed today in the presence of such an august audience. So this was a 62-year-old male. The left eye, as you can see here, has had a few injections or 1 or 2 injections of the dexamethasone implant, but the patient did not follow up with treatment and eventually ended up with retinal atrophy. The right eye, which shows evident vitreomacular traction with ERM, and he had been advised an intravitreal dexamethasone implant for the same. So for this patient, obviously, the initial management was surgical, and again, in the interest of time, I will not go through the entire video, but the point was to remove the taut hyaloid in 2 different zones so that you don't end up de-roofing the fovea. And eventually, we purportedly, or let's say deliberately or intentionally did not touch the ERM because there was no tangential traction. We will contrast this with the other case. So the patient's vision improved dramatically, went from 636 to 612, 69 parts, eventually underwent a cataract surgery, and he did well without any injection. Now, in this case, we have evident proliferative diabetic retinopathy with cystoid macular edema. This is the left eye, which shows an evident ERM. In this case, unlike the first, we will see that there is tangential traction. So here again, the initial management was surgical. We removed the ARM, but there was persistent edema 3 months after surgery as well. So at this point in time, we chose to give the patient a dexamethasone implant, and to good effect. The foveal contour was not restored in toto, but there was resolution of the intraretinal and subretinal fluid. I understand that there are residents here, so I just wanted to show the technique of injection of the implant. So you go in, bevel down 3 to 3.5 millimeters from the limbus, and then release. Just dab this, and in case this has been combined with a cataract surgery, the viscoelastic is removed afterwards. The second case is how not to inject the dexamethasone implant. So first we will see, and this is again combined with the cataract surgery, not too uncommon scenario these days. So here you see the surgeon is removing the viscoelastic prior to the injection. And then he goes in, as you will see, bevel up, not facing the optic nerve, enters near horizontal and injects the implant in the back. So now we have a situation where we have an implanted lens with the rent. So because the surgeon was skilled, he managed to actually do a reverse optic capture, and the patient did very well. There was no problem with the resolution of the macular edema as well. But this is how it is. So as you can see, there's a stable IOL with the implant still working, although it was in the back. So I think I'll end here. Thank you very much. And the points that I want to discuss is that 2 eyes of the same patient can receive different injections. I think the whole point of having multiple injection is to tailor the treatment to the patient and not have, say, a straitjacket formula saying that, okay, we have to start with X molecule first or Y molecule first. Everything is individualized based upon the patient's needs. Thank you so much for your attention.
Thank you, Aditya, for the presentation, bringing out points and complications related to the injection. I think for the want of time, we move on to the next presentation.
Now I invite Dr. Vishal Dedia for his talk on SIPS and SINs, a diagnostic challenge put of 2 cases.
Good morning, everyone. My topic for today is SIPS and SINs. I'll be 9-year-old female referred to us with an acute loss of vision in the left eye following cataract surgery done elsewhere 4 days back. There was a mild boring pain, no redness in the left eye. Cataract surgery was uneventful. Patient was a diabetic, well controlled. She also suffered from non-specific joint pains. BCVA was 6/60 in the left eye. Intraocular pressure was 8. Slit lamp examination was within normal limits. No signs of inflammation and no wound leak. This was the fundus examination. Showed a normal optic nerve head in the left eye. Superior temporal retinal detachment involving the superior macula with ILM folds and choroidal elevation. Careful peripheral examination did not show any breaks. The OCT of the left eye showed SRF involving the superior macula. FFA of the left eye revealed multiple pinpoint leaks in the early phase, which increased in the mid and the late phase with pooling of the dye in the subretinal space. The left eye angiogram was normal. The B scan of the left eye showed localized thickening of the choroid and the sclera with an overlying shallow retinal detachment. There was a no classic T sign. Systemic workup was done. The MRI with angio of the brain and orbit concluded that the choroidal and the scleral thickening was inflammatory in nature and ruled out any evidence of tumors or mets. The blood investigation was done for uveitis. RA factor was positive. There was a raised ESR. Other tests like MAL2, TPHA, ACE, and ANA were negative. These were the serial photographs. The patient was started on systemic steroids 1 mg per kg per day. Also, a rheumatologist reference was given, and the patient was started on weekly methotrexate. Patient improved from 6/60 to 6/6 in a span of 5 weeks. These are the serial OCTs, and initially you can see in the second OCT there was the increase in the SRF in the macula. The fluid had shifted from the superior quadrant to the inferior quadrant and then followed by complete resolution. Differential diagnosis we thought were choroidal tumors, uveal effusion, reg RD, CSCR, VKH, optic neuritis, and pseudotumor. But then surgically induced diffuse scleritis and necrotizing scleritis have already been reported print literature few weeks to months post cataract surgery. But this case was different because it involved only the posterior sclera, no involvement of the anterior segment, occurred 4 days after cataract surgery, and the B scan also didn't have a classic T sign. So we termed it as a surgically induced posterior scleritis. This is a very rare presentation, and also in the contralateral eye, we did give pre and post-op systemic steroids, and we didn't find any such complication in the left eye during cataract surgery. The second case was a 65-year-old male resident of Rajkot came with complaints of severe pain in the right eye since few weeks, along with redness and diminution of vision. Past history of 2 retinal surgeries done elsewhere in the right eye in the last 6 months. Systemic history, not significant. Medical history, patient was on topical steroids and lubricants post-surgery. BCV in the right eye was hand movements. IOP was normal. This was the photographs. The slit lamp examination showed a bluish discoloration of the inferior temporal sclera, along with congestion of the deep episclera and the scleral tissue around. Rest of the anti-segment was normal. Fundus examination had a total retinal detachment with macula off, along with grade C PVR. We can see the epiretinal membrane and the subretinal band inferiorly with silicon oil in situ. So we did 3-step management. The first, initially we planned a partial thickness scleral graft, which was done under the cover of systemic steroids and anti-inflammatory drugs. The patient tolerated the graft well. After a few weeks, we planned a revit. The infusion port was placed away from the transplanted scleral edge. Along with an inferior buccal membrane peeling was done. The subretinal band was removed. PFCL endolaser and re-silicone oil was inserted. 3 months later, we did a silicone oil removal. The patient did well from hand movements to 6/12 vision. The foveal contour returned back to normal. So again, in since also the most common cause is cataract extraction. In this case, the patient treatment is usually medical, but this patient required an surgical intervention because of impending perforation, and also we were planning for the VIA surgeries. As this is immunological, patient also needed future medical therapy to avoid a graft failure. Thank you.
Thank you. Dhanashree, comments?
Very nice cases. Only thing, one comment is that if you see an RD very soon after the surgery, here you have done cataract surgery, but very often in retina surgeries, we do come across cases where there is an early recurrence. So best is not to rush in for a resurgery, and there may be some associated exudative component. And second thing I want to ask you is that do you do any scraping or anything to rule out any infectious scleritis in this necrotizing variety?
No, ma'am. We just did the blood workup because the anti-segment looked okay. The incision was clean. So we went with the blood workup, and the B scan also showed an exudative ID. So we went with the steroids initially.
Because sometimes I have had about 2 cases where after a pars plana vitrectomy, all the 3 sclerotomy sites showed necrosis. And it turned out to be infectious. So they did a scleral scraping, and from the scraping, I think in one case, I forgot what was the organism, but infectious organism was isolated, and then we had to treat them with higher antibiotics, and then the
second case, the sclera was very thin, ma'am. So we just did dissection of the conjunctiva and placed the graft.
All these cases, the sclera was very thin. The uvea was shining through, and I was a little bit scared that it may perforate and all that. But even then, the scraping was done carefully by the cornea consultant, and then the high antibiotics were started based on the sensitivity report. And over a period of 1 month, the sclera became normal. I mean, we did not need to do any grafting or anything.
Sangeet, comments?
Yeah, not a comment, but just a small question I would like to ask. Sometimes we need to do a sequential surgery like cataract surgery and then VR surgery maybe 3 to 4 weeks later. And supposedly after doing a cataract surgery, patients develops this problem. So any precautions you take for a VR surgery, then should you schedule the VR surgery as usual? Or should you postpone? What would you advise?
The necrosis, sir, or the exudative ID?
Yes, the
necrosis.
After cataract surgery, you develop scleritis, and then what will be your plan? Because you have already planned a VR surgery later.
Yes. So because this was already patient with detachment, and we were planning 2 VR surgeries later on, one with the oil and then the oil removal. So that's why I had gone with the scleral graft. Because after the graft, because if I had planned a VR surgery initially directly, there was a chance of perforation if I had to put an infusion, and then from that site of necrosis, the fluid might digress. So that's why we planned first a scleral graft, waited for a few weeks. Anyways, it was a 6-month-old RD, chronic RD. So we waited for a few weeks. Once the graft settled, then we went for a resurgery, and then we placed the inferior, the port away from the scleral side.
I think that's one point I would like to highlight, because so if we attempt surgery sooner, what will happen is, like, during the surgery, your sclerotomy port will start melting away, and you will not be able to control the surgery. The eye will leak like anything. So I think so that is very important. You have to wait. You have to keep the things under control. Maybe if grafting is possible, or even during the surgery, if you are planning a surgery, keep a graft ready. You may need that on the table also.
Last question.
So I wanted to ask Dr. Jeet, the first case was RA positive. So how significant is this RA positive, and do we need to do anti-CCP in all cases?
Yes, ma'am. If RA rheumatoid factor is no RA factor, is rheumatoid factor. If it is positive, then yes, we have to go for anti-CCP, because low titer rheumatoid factor positive from any labs in India, they are not so significant. And for us, it's more than 3 times upper limit of normal that we consider positive. Any like 36 or 24 something rheumatoid factor positive, we usually don't consider. Yes, of course, if the clinical pattern picture is fitting along with that, then we can consider. But if possible anti-CCP is there, then we should go for it.
So better to do anti-CCP if RA is positive.
Yes, ma'am.
Yes, thank you. Thank you.
And just one small comment. And any case of since whenever you are doing subsequent surgery, even if you are doing it very later, like months later, there is always a risk of precipitating the sins again. So you need to do it under steroid cover.
Yes. The patient was kept on long-term steroid, ma'am. The last pick was almost 2 years later. The patient was maintaining.
Yeah, so if you plan SOR like after many months, you still need to keep that in mind that you might develop sins again, and you have to use pre and post.
That's a very important point to keep in mind.
Ma'am, so one question I had to ask: if you are doing a graft, then how long do we wait for the next surgery? So when we are planning a revitrectomy, so how long do we wait for a vitrectomy?
I think, as I mentioned, you can do it earlier, because once you put the graft, then
We
relatively
waited for 4
early.
weeks in this case with steroids.
No, that depends on the retinal situation also. If the retinal situation demands an early surgery, you can always change the site of the sclerotomy and then do the surgery, leaving the graft intact. So that is one possibility.
Will there be a chance of rejection because of the surgical inflammation to the graft site, even if we change?
I don't think the scleral graft gets rejected like that. It's very, very rare.
We'll move on to very nice case.
So,
Thank you very much.
if I may just one comment over here. So when you're talking about sins, you definitely, if you have encountered a case of sins, I would like that all the patients to baseline have an ESR CRP levels, because many of the times the point being here of resurgeries. So first of all, I would like to see whether the ESR and CRPs are normal or not. So if the ESR and CRPs are still high and your the disease requires an immediate intervention, so possibly that would be under the control of a methylpred pulse or something of that sort. You can start 2 days prior on the day of surgery, post surgery, so that you cannot encounter.
Yeah, that's what she mentioned.
Yeah, so now
the next presentation.
Now I invite Dr. Bhavik Panchal for his case on Blau syndrome.
Good morning, everyone. It is such a wonderful thing to see an entire full house here. Good morning to the panelists as well. So this case is an interesting case about a 2.5-year-old kid who presented us with a bilateral granulomatous uveitis and a complicated cataract. This kid was from Saudi Arabia, staying in India, but parents working there. There was treatment started there, partial response to oral and topical steroids, and they referred here because they could not manage it further. At presentation, visual acuity was 2800 in both the eyes. In the course of follow-up, child developed fever, arthritis, and skin rash as well. And I'll come to the genetic testing at some point in time. So clinical presentation, at presentation, there was chronic granulomatous uveitis, and you can see the complicated cataract in both the eyes, right, both and left. So no doubt the child also had amblyopia as well. So first we managed the kid and control the inflammation. Eventually we had to go in for a combined vitrectomy and lensectomy. Intraoperative, we found that there were multiple sago granules which were noted. So this is a very classical sign seen in patients with sarcoidosis. So we had a suspicion of pediatric sarcoidosis in this case. Over a period of time, the child also developed arthritis and dermatitis. This is where the child was under care of a pediatric rheumatologist, and we went ahead with whole genome exome sequencing. And clinically diagnosis of Blau syndrome was made because we had all the three components: uveitis, arthritis, and dermatitis. And the genetic testing came to be positive as NOD2 mutation. Coming to the investigations, the child had mildly elevated AC levels, weakly positive ANA. So JIA is pretty common for such kids to diagnose because the systemic symptoms appear later. And here the whole genome sequencing definitely helps us to understand, and a definitive diagnosis of Blau syndrome was made. So initial control was with topical and systemic steroids. Methotrexate was added to the kid, but we found that it was inadequate. Eventually, after the surgery, and the rheumatologist shifted the kid onto subcutaneous adalimumab. And at this point in time, the kid was better. We left the kid aphakic because we know that any kind of IOL is going to induce inflammation. Once the inflammation settles down, we can always proceed with an IOL subsequently. So over the course of time, the child developed recurrent uveitis, scleritis. That is where the adalimumab kicked in and helped us to control. So this is a wonderful story about a kid who had all the systemic features suggestive of not just uveitis, but something beyond that. This is a post-operative photograph where some corneal scarring which was present. The sago granules, once you start the treatment, the vasculitis resolves. In case of sarcoidosis. So few important points here is that Blau syndrome is often misdiagnosed as JIA because the systemic symptoms appear a little later. So always keep in mind, for a child, don't be satisfied with just the ocular features. Look for systemic features, refer to a rheumatologist. So we have sir here as well. And with Blau, there is a granulomatous pan-uveitis compared to GI, just an anterior uveitis. Higher complications are associated with Blau, that is cataract, glaucoma, and band keratopathy compared to GIA. And you can have screen granulomas as well, where there's a non-caseating granulomas, how you see in sarcoidosis, which are also present in such. Systemic signs appear later. Ocular features can present much earlier. It is important to add immunosuppressants as early as possible. Sometimes you may have to go for a TNF-alpha inhibitor as well. I personally prefer not putting IOLs for such children who have cataracts and uveitis, So to conclude, high suspicion rate in children with chronic granulomatous uveitis. Genetic testing is essential for confirmation of such kids. Adalimumab is key for long-term inflammation control, and surgery should be timed after inflammation control, and multidisciplinary care ensures optical outcomes, like in this case. So the child is doing very good with contact lenses at present, and in the future we plan an IOL for the kid when everything settles down and his amblyopia improves with glasses. Thank you so much.
Thank you, Bhavik, for the excellent case. And we have Dr. Jeet. We would like his comments, and also a special comment on how to use the biologics and which are the best biologics when it comes to uveitis, and what are the newer biologics which are going to come. If you can briefly tell us.
So Dr. Bhavik very well presented case. Blau is very rare. I have seen just 1 or 2 cases in my till date. So it's very rare. But yes, in pediatric patients, if you have bilateral uveitis, you have to think for Blau or pediatric sarcoid. And you have put one sentence that in resistant case, use anti-TNF. But in pediatric patients, always go upfront anti-TNF because in pediatric patients, oral treatment, oral immunosuppressive medicines are not working. They have very high metabolism rate. So even the dose of methotrexate is also high. And they are usually not working that much. So we usually directly go for anti-TNF in pediatric patients.
Could you elaborate on that?
So sir said so many questions actually.
No, for the anti-TNF, because as you rightly said, in pediatric uveitis, it is now being considered as the first line of treatment.
Yes, sir. So that is like because the immune system of adult is different from the pediatric population. They are still learning. So the molecules that we have like cyclosporin, methotrexate, azathioprine, they are not working that much. While TNF is like surgical strike, it directly blocks the TNF. So it blocks the immune inflammation that is directly going through the NOD2 mutation or nuclear factor kappa beta or all the pathogenic factors that are involved in spondyloarthritis or GIA. So we get very good results, and the penetration is also very good. While the drugs, we don't have that much penetration to cross the retina blood barrier. So that may be the fewer reasons why anti-TNF are working much better than the oral molecules. And the other things like we usually avoid etanercept, which is also anti-TNF, because there are few factors that may increase that. There are few studies that showed that there are main chances of uveitis. We go for adalimumab because it is cheaper than anything else. But the thing is that if we want to continue adalimumab very longer, then there is chance of antibody formations. So down the line, there is decreased effects of adalimumab. So the newer molecule, which is Symphony, golimumab, which has very least chance of antibody formation. So it is once a month therapy. All TNF are safer. Golimumab is much safer. In adalimumab in India, the country where TB is very prevalent, we usually little scare of tuberculosis. But in pediatric populations, like they have been given BCG, so they are usually safer for that. But in adult populations, we usually think that we have seen that even after going for Montauk's test, chest CT, and quantiferon, everything negative, still we have seen patients getting tuberculosis. So it's difficult to keep in mind about that thing.
Thank you. Thank you very much for your comments, and thank you, Bhavik, for the nice case.
Thank you very much. So now I invite Dr. Rudvish Pandya for his talk on SLE retinopathy masquerading as post-fever vasculitis.
Yeah, so this is a case of a 21-year-old female who came to us with complaints of decrease in vision in both the eyes since past 2 months. Now she complained, she gave history of typhoid fever 2 months back. On clinical examination, you can see a kind of multiple soft exudates in the posterior pole with superficial hemorrhages. On the OCTs, you have IRF, SRF, as well as thickening of the NFLs. Now let's join the dots. When we see a female who says, I have a fever, typhoid diagnosed 2 months back, no systemic illness, and you see this picture, this clinical picture with this OCT, probably you might think it's a post-fever vasculitis kind of a thing. So patient was requested to get the prior reports. So in that sense, we could know what kind of diagnostic therapies were used, or sorry, tests were used for the diagnosis of typhoid. When she presented next, she had a sudden decrease in vision in the right eye. You can see over here the changes that have occurred now. There is a fresh vitreous hemorrhage. There is increase in the retinal hemorrhages. If you see very closely over the superior part over here, with a pointer. Okay, so at 12 o'clock, if you can see, there are venous occlusions. If you zoom in and see over here, you can see arterial occlusions also that are there. If you see the right eye, you can see there is bleeding of the veins and everything. Clinically, we do not see any kind of neovascularization over here. So we are like, okay, why is the vitreous hemorrhage occurring? Let's get an FA. And when we see the FA, this is the picture what we see. So the outstanding part, I'll not go more in describing the features, but if you see over here, there is an extensive CNP areas. There is an extensive angiographic leakage, which does not correlate with the clinical picture. There is no clinical signs of active vasculitis, if you want to say. Like you might see perivascular exudations and all. So now again, let's go back and see that, okay, if we join the dots over here also, the diagnosis of, it's not post-fever vasculitis straightforward. So now here I would like to give one clinical poll that what are those conditions where you can see extensive angiographic leakage, but clinically you do not see anything. So few of this condition, one is SLE, Suzak, Takayasu, or Behçet's are the clinical diagnosis which you may have. So keeping this in mind, our patient did not have any of those things and no systemic illness. We thought, okay, let's go ahead and again revise those charts. It's a female, 21 years of age, multiple soft exudates in the posterior pole area, angiographic leakages and all. The things that were also there which came over the history was patient was possibly having polyarthralgia, alopecia. She complains of some kind of depression. Her husband says some altered behavior, schizophrenic kind of a thing. And if you see within 1 week, there is a vitreous hemorrhage. So rapid progressive course, we thought let's rule out SLE. Now typical presentations, we all know Pershers like retinopathy is a typical presentation. But if you have something atypical, then what next? So in that point, rather, along with ANA, we would also want to rule out aplastic serology also in our patients. Along with that, we also rule out renal pathologies as well as pulmonary arterial hypertension. We have all our reports and we diagnosed it as an SLE retinopathy. But over the course of time, this one clinical pearl, so that if you have, generally we know if it's an optic neuropathy, you would consider as a neurological thing, start the patient with a cyclophosphamide or rituximab. But again, if you have SLE vasculopathy also, consider them as a neurological case, go ahead and give a cyclophosphamide or a rituximab in this case. In our patient, the patient was given monthly cyclophosphamide for 6 days. From the retina perspective, we had a couple of minutes, if I can. Okay. So patient was lost to follow-up. If we can see over here, no retina management has been done, but just on immunosuppression, the hemorrhage and everything is gone. But to look for disease, activity and all, we again got an F. There were still some leakages. Patient was planned an Avastin followed by laser. Still, but despite laser, despite Avastin, there is a large NVD which was there, which does not explain patient has received 5 cyclophosphamides by this time. After the laser, if you see over here, you can see a crunch that has occurred. We operated the case, and this is a 4-month or 4 weeks post-operative photograph. Now the patient's last follow-up was in March, and SOR and everything was done. What I learned from this case, that unlike the typical presentation of a podcast,
I think we learn from Jeet. Okay. Dr. Jeet, can you comment?
I have
just one comment
for him also.
Yeah.
Very well presented case. So the management, ophthalmologic part management is, of course, all the ophthalmologists they are here, they can comment. From our part, you have done great job. Cyclophosphamide is the molecule of choice that we usually go for acute case, because the effect of rituximab will come after 1 month. So in acute case, we usually go with cyclophosphamide and steroids.
And how long do you continue the treatment?
It's a lifelong.
That's it.
So we have to be very blind and blank to
That's
tell the patient
important.
on the face that you have to take this treatment for lifelong.
Yes, that's because they have this relentless progression of the disease no matter what you see. So lifelong treatment is extremely important.
The more I would like to ask you this question is, despite having 5 cycles of cyclo, the patient on HCQ, possibly he's been given to start with, you always give solmetrol before you give a cyclo. Despite all these things, despite the anti-VEGF, despite the lasers, the things are still progressing, right? It progressed like anything. If you see, even after the laser, there was prolific NVDs that were there. And just for our retina colleagues, would you have treated something different? Because I did an ad laser, and in 2 weeks, you can see that NVD has gone into a fibrotic and led to a, posterior pole involving tractional detachment.
Your first FA picture which you showed and the laser done.
So I'll just, this is the timeline. So if you see over here, this is the month, is the 6th month. If you see the date over here, it is the 6th of March. This is the first initial photograph where we said the patient has to go ahead for the lasers and all. So this is on 14th of June. So at this time, if you see, even after the laser, even 5 cycles of cyclophosphamide.
No, I meant when did you start the first laser?
The same day and 2 weeks apart. Okay. 2 weeks apart. Yeah, because the another thing what we have to keep in mind is it's an inflamed eye. You cannot do fast lasers because it will in turn, if you do, it will in turn increase your inflammation by that sense. So if in a retina, if you want.
I think SLE is not like other vasculitis. SLE is something which progresses very fast, and the laser should be done as earliest as possible, and the maximum laser be done with maximum antibiotics.
But actually, for that point, we are given Avastin.
Yeah, but
to counter that point,
I think we'll discuss. Great case, and I think a lot of points that we've learned from such cases. Most important is the lifelong treatment and early aggressive treatment are the 2 take-home points. Next.
Now I invite Dr. Anushka Prajapati for her case on progressive outer retinal necrosis associated with herpes simplex virus in a PLHA case.
Respected delegates and faculties, good morning. I am Dr. Anushka, resident doctor from Gujarat Adani Institute of Medical Science, Bhuj. My case today is progressive outer retinal necrosis with herpes simplex virus in PLHA patient. Progressive outer retinal necrosis is a rapidly progressive necrotizing herpetic retinopathy typically seen in severely immunocompromised individuals. It is characterized by initial geographic opacification of the deep peripheral retina without prominent vasculitis or vitritis, followed by rapid progression to involve the entire retina. It is commonly associated with varicella zoster and uncommonly with herpes simplex. It usually presents unilaterally with bilateral involvement as the disease progresses. The visual prognosis is poor as the disease progresses to retinal detachment. This case is of a 33-year-old Hindu male patient with complaint of diminution of vision in right eye since 3 months. The defect was sudden and painless. The patient is a known case of PLHA since 1.5 years on antiretroviral therapy. He is a habitual tobacco chewer since 10 years. There was no other drug use or systemic illness or any significant family history. On examination, the visual acuity in right eye was 6/60. The left eye was 6/6. RAPD was present in right eye. 15-degree exotropia and alternate exotropia was present in right eye. On slit lamp examination, the anterior chamber was quiet and no significant findings were found. Dilated fundus examination was done after that. The fundus findings are 360-degree blurring of disc margin, mild vitreous haze, multiple deep whitish lesions in the peripheral retina, and a few coalescent patches of retinal necrosis. The retinal vessels were spared. OCT was done. It showed outer retinal disorganization with posterior vitreous detachment and mild vitritis. The blood work was done, which showed mild leukocytosis with CD4 count was in 800s. Varicella zoster markers were negative. HSV1 and HSV2 were positive, as well as CMV was positive. The patient was started on intravenous injection acyclovir 500 mg in 100 ml NS. The patient was also continued on tablet dolutegravir, lamivudine and tenofovir once a day. The progression was rapid deterioration of the condition with the vision dropping to hand movements, perception of light and faulty projection. Repeat fundus examination revealed formation of tractional band superiorly towards the macula. Thus, the findings were right eye with visual acuity of 660, RAPD, fundus showing multiple whitish necrotic lesions with mild vitritis, OCT findings showing RP disorganization, and viral markers showing HSV1 and 2 association in a PLHA patient with CD4 more than 800 with rapid progression to visual acuity of HMPL-PR inaccurate with development of tractional band. The differential diagnoses were progressive outer retinal necrosis, acute retinal necrosis, and CMV retinitis. The other two have more vitreous component and the vessels are not spared. Progressive outer retinal necrosis is a rare clinical entity seen in immunocompromised. Documentation usually shows association with varicella zoster and less commonly with herpes simplex. CD4 counts are usually on the lower sides around 100 per nanogram. This case here is unique that the CD4 counts were in 800 and the zoster was negative. It is important to screen patients with known factors such as PLHA patients for retinal pathologies. Prompt diagnosis and treatment are necessary to limit the retinal damage and preserve vision. More vigilance and awareness can prompt quicker vision saving.
Dhanashri, Sangeet, comments? Differential diagnosis, POR and CMV. Yes.
What is the titer of CMV that you consider significant in this case?
Sorry.
Because the titer is very low. Just asking that in any case of PLH or any other case of non-PLHA, what is the titer of cutoff titer that you consider significant? Because CMV is very, pan present. In many cases, you can see low titer positive.
So I think there is no role of CMV titers in diagnosing CMV retinitis, okay? No value except PCRs. So absolutely no value of getting your IgG, IgM levels done. So this is absurd. That is one point. And basically CMV is purely a clinical diagnosis,
Yes,
but
sir,
yes,
hemorrhagic
PCR
presentation.
could be a helpful tool. But other than that, there is no other any investigation which would help for CMV diagnosis.
May I add a point?
Yes.
Hi Anushka, good presentation. This case, though the diagnosis I would differ, it looks like a case of acute retinal necrosis only, because ARN can happen in PLHA patients, and you said there's an amount of vitreous inflammation, and the lesions are a little more peripheral. So PORN, it was described in early 1990s, and that time we did not have OCTs. So it was described as an outer retinal involvement of the macula, where in very severely immunocompromised patients where the CD4 count is very less, maybe less than 50 or 100. So they don't have any immunity. So they present as lesions in the macula where you can see the vessels passing over them. So clinically, it looked like an outer retinal necrosis. That time we did not have an OCT. So I'm Dr. Spurti Mandadi. I did my Uvea fellowship from LBPI in 2018.
But it's not always posterior core, because we had done PORN, came out in the era of HIV.
Yes.
And I did my fellowship, and we were the first to present PORN. Usually in those cases, it was periphery, outside the arcade. It's actually not the posterior pole disease.
So we have now recently published a paper where we have correlated the OCT findings of the classic PORN cases and shown that the involvement is actually inner retinal and outer retinal and total retinal involvement. So maybe it is a misnormal that we...
So recently there's a publication mentioning that you need to change the terminology.
Yes.
Thank you very much. I think we move on to the next presentation, which is
So now I invite
presentation.
Dr. Abhishek Heranjal for his talk on case-based insights, aflibercept in managing DME and wet AMD. There is a small announcement. I got a lost car key of Honda car. So if anyone's key is missing, kindly contact me.
Hello.
Honda car key. Otherwise, ma'am will give it for best presentation.
Hello. Good morning, everyone. Today, I'd like to share two real-world cases that shaped my approach to anti-VEGF therapy, not just in terms of treatment, but also in terms of clinical decision-making. Here is the first case, a 49-year-old female who came to the OPD with decreased vision in both eyes. Visual acuity of 612, the anti-segment findings were within normal limits. She was a known case of glaucoma and under treatment and a recently diagnosed diabetes. Fundus examination revealed bilateral diabetic macular edema, presence of hard exudates inferiorly, and presence of NVE and NVD, which were further confirmed on OCT and angiography findings. And the case was labeled as a bilateral proliferative diabetic retinopathy with diabetic macular edema. So usually in such cases, I go with the PRP first and then followed by intravitreal injections. I chose aflibercept here. I do not give any loading doses. I went on directly with the PRN regime. And what we observed was a rapid improvement in vision following the initial treatment. Visual acuity improved to 6.6. The retreatment criteria here was an increase in central foveal thickness of more than 20%, or a decline in visual acuity, or the presence of an IRF or NSD. So under a PRN regime, the patient remained stable, and even with extended injections, the stability was maintained for about 16 to 20 weeks, which was very good. Despite minor fluctuations throughout the period, I saw that I did not change the course of treatment. And over a period of 4 years, with repeated injections, I achieved a normal ellipsoid zone, normal foveal contour, and a maintained 6.6 visual acuity. And the interval between injections was approximately ranging from 16 weeks to 22 weeks, which was a very good case study for me. So overall, I injected around 10 injections in the right eye and 9 injections in the left eye over a period of 4 years. So what worked here was a good anatomical and functional response post PRP laser and anti-VEGF therapy. PRN maintained stability over longer intervals, that is around 16 weeks to 22 weeks. What is interesting is, despite extended intervals, the vision remained stable. It also suggested that the patient was a good responder phenotype. What I changed or considered is I did not switch despite having recurrences, and I continued the PRN regime due to a sustained response that I got. So not all DMEs require aggressive fixed dosing like 3 loading doses followed by PRN or TREX. In selected patients, PRN can safely extend to even more than 4 to 5 months. Compliance and OCT monitoring is the key in this case. The second case is a different case. Again, a 49-year-old female entrepreneur came to my OPD for a routine examination. She said that my left eye vision had dropped, but on examination, her visual acuity was 6.6. Anterior segment findings were within normal limits. Intraocular pressures were normal. The right eye fundus was normal. The left eye seemed to be normal. As like many of us do, the initial thought was reassurance. There is nothing wrong with you. But the patient said, "Sir, I'm serious." So that's when I paused, decided to reevaluate, did a OCT scan, and on deeper assessment, I found that there is some subretinal fluid with PEDs there. So that was my reaction. And then I went on for reassessment, and there I found that there was the PED indeed, with some drusenoid deposits nasal to temporal to the disc. Again, the infrared and the autofluorescence imaging showing the same, with hyperfluorescence around the macula, showing presence of SRFs. And I went on with an angiography, FFA plus ICG, and I could see beautiful polyps just beneath the PED, which were active and leaking. So my diagnosis changed. Right eye was absolutely normal. These were the polyps under the PED. And the diagnosis changed to peripapillary exudative PCV. So the treatment options we have is a PDT or PDT with some anti-VEGF monotherapy or aflibercept. So I chose aflibercept monotherapy. Went on with giving 3 loading doses of aflibercept on a monthly interval. The vision improved to 6.6. Patient was happy. The PED regressed beautifully. The polyps also regressed beautifully. This can be seen on the serial OCTs that I have shown here. Post the loading doses, there was remission for almost 4 months, and there was activity after that, for which I again injected 2 more injections. But to my surprise, the PED did not come down. The SRF was increasing. So I paused here and I thought whether injecting is the way to go or I should do something else. I went on with an angiography, and to my surprise, there was a CSR leak which was right above the PED, which showed that this was not just a case of PCV anymore. It was a pachychoroid spectrum with an active CACR component.
Can you summarize, please?
So as a reflex, you usually tend to inject and not re-evaluate the case. So here, when I started the patient on aplenorol, the SRF regressed. Post that, injections worked for around 16 weeks on and off. And we have a remission period for almost 48 weeks in this patient, which is very rare in cases of PCV. So not all SRFs are VEGF driven, and pachychoroid spectrum requires our different kind of thinking. When the response always pause, rethink, and just interact.
And right, and you have very nice things. And very fast, we will have to develop and say. So we need to talk at the end of this session and have like
just conclude.
Thank you very much. A lovely audience, very good speakers, amazing interaction, and very good panelists. But I would like to introduce Jeet here. I almost don't recognize him because I know him only on phone. Jeet Kariye. And his father is my friend, with the white hair license. Catch him walking in Kamati Bagh. So thank you very much, Jeet. It's been a pleasure having you, for taking the time, for looking at our cases, the works. We would like to give you a small memento.
Thank you, ma'am, for inviting me here. Thank you.
Your father is going to be very proud of you.
So we come to the end of the Uvea session, and I would like to thank all the panelists, and we move on to the surgical session. I would like to invite Dr. Manish to take over the session, and Dhanashri and Sangeet, you can be on the stage as one of the panelists, and I have Kaushal, Mukesh, and Parth as more panelists. And I would request Kamar sir as our mentor. Please come in the front, sir. Please, sir, come here. I am not going to ask you questions, but we would like to have you come in front, sir. Dr. Ji. Doing it from here is better. Yeah, Kushal will announce. It's okay. Yeah, you could session, please. Yeah. Our keynote address speaker, Dr. Sangeet, is going to speak on misadventures in macular hole surgery. I specifically asked him to speak on this. As we all know, macular hole surgery is like a bread and butter to us retina specialists. So he's going to have some nice insights into macular hole surgery. Over to you, Sangeet.
Thank you, Ale. Thank you, Parth. Thank you, Kushal, for inviting me here. I just start with, it's a little bit of talk on evolution of macular surgery rather than just on misadventures. So macular hole is still, we need to understand what is going on. Though we have so many options of doing macular hole surgery, but I don't know whether we have understood the thing but still now or not. And although the first descriptions of macular hole surgery were seen about 150 years ago, it was thought at that time to be an untreatable condition until Sir Don Gass classification appeared in 1988, and then Kelly and Wendell published first successful closure of macular hole in 1991, when they achieved 58% closure rate in their first paper. And from then onwards, the retinal surgeons, they are striving to achieve a 100% closure rate on in macular hole surgery, and with time the surgery has evolved. So during the first time, what Kelly and Wendell had proposed was they just did a complete vitrectomy and nothing else, and they saw that 58% of the macular holes closed just by doing a complete vitrectomy. So I'll just go on one by one what techniques, what we have done throughout our careers. And this is the first thing that we started to do, that was the ILM peeling with no flaps. So first we used to scrape the ILM, then we moved on to the pinch and peel technique. So, but I heard Klaus Eckert when he came to India in 2009, he said do a maximum ILM peel at that time so that your closure rate increases. So we started doing it arcade to arcade ILM peel, giving a maximum relief of traction as what we used to understand at that time, and so to achieve the closure rate. So this is an old video. I'm using the ICG dye in this patient, and you see we started from the arcades, then we moved towards the inside and did a complete ILM peel, then we did a fluid air exchange and used a long acting gas at that time to tamponade the eye. And of course, we were doing well. The patient had a good closure, and we almost achieved 80 to 90% of our macular holes used to close at that time. But then Jerzy Nawrocki in Poland, he introduced a technique called the ILM flaps. So what he did was, for large macular holes, he suggested that we should go in for flap technique. So this was a patient of large macular hole. So how we used to do at that time, we just continued from where we had left the ILM peels. We again started from the arcade, we moved in, we tried to create a ILM flap, and then we trimmed these ILM flaps, and then we used to stuff this ILM inside the macular holes to achieve that closure. So here you see the trimming of the flaps is being done, and these flaps were then stuffed inside the macular hole. Though we got a very good closure rate, we improved on our closure rates, but post-operative RPE atrophy was very common when we used to stuff these flaps inside the macular hole. This was a patient, luckily I did not had a RP atrophy and large macular hole we were able to close successfully. But that was a big problem, the RP atrophy which was happening after doing this stuffing technique. Then somebody suggested we just, instead of stuffing, we just overlay the flaps onto the macular hole, and then came the technique which we call the temporal flaps, which became again very popular. We used to create a small temporal flap and hinge it over the macular hole here and remove the rest of the ILM to again increase the closure rate. And you see, just overlay the flap over the macular hole, no stuffing it inside the macular hole. And again, we got good results doing this technique also. So we kept on improving as our understanding of the macular hole surgery improved day by day. So this was again a temporal flap, then closed with the gas, and patient was asked to lie in a particular direction, and this is the post-operative picture. Again, temporal flaps, reduced the amount of RPE atrophy that we used to get while we used to stuff the holes. But still, there were persistent macular holes. We had sometimes to do free flap techniques. Again, take the flap from somewhere else and then put it inside the macular hole or overlay it over the macular hole to complete the hole closure in these persistent macular holes, which failed to close in the initial surgery. So in this, because we used to do a larger ILM peels at that time, so we had to take the flaps from beyond the arcade, and then we had to bring it towards the macular hole, then somehow stuff it or overlay it over the macular hole, put in and use again the gas or oil, whatever the tamponade. But again, the RP atrophy was seen commonly in these patients. Then Dr. Tamir Mahmood, he proposed a retinal autograft. So this was a patient with large macular hole with a retinal detachment along with it, and this was one of my first cases of what the autograft. When we did a ILM peel, and then we took a graft from the peripheral retina where the retina was detached. Initially what we used to do was we used to do cauterize the edges. Fear of bleeding was there, but now we don't cauterize the edges if we have to take the graft, and then we move the graft over to the macular hole, overlay it, or again you can underlay the graft inside the hole and then use silicone oil or gas as a tamponade. So this was a patient, again we did a fluid air exchange and we used silicone oil as a tamponade in this patient. This was how, what they said was that it achieved a better anatomical outcome, gave a better anatomical outcome, but again the functional outcome was not as good as we thought would be. Somebody suggested put amniotic membranes in these persistent macular holes. So again, we tried that also. This was again a large macular hole. Again, we harvested an amniotic membrane graft. We had to do a 4-port vitrectomy in these amniotic membrane cases. Take the amniotic membrane, and then we have to take care that we are using the amniotic membrane the correct side up. So we stained it with brilliant blue. Again, place it over the macular hole. This particular case I'm doing under silicone oil, so that better. But again, these amniotic membranes, people say that they disappear with time, but I have now 8 to 9 years I've been doing, and I have not seen a single amniotic membrane going away from from overlying the retina. Somebody then suggested do a T-nonce patch instead of amniotic membrane. So because amniotic membrane is not so freely available, we did T-nonce patch. This was again a patient of a persistent macular hole with a retinal detachment. The advantage of T-nonce patch was it was easily maneuverable rather than the amniotic membrane, so which was not that easy to maneuver. And then again you position it inside the macular hole. This is this particular technique sometimes do help us in this persistent macular hole with detachments. Like after detachments, you get a good closure after doing some kind of flaps. But over the years, what I generally now shifted to was doing inverted flap technique, and I used PFCL bubble over the flaps to easily overlay them over the macular hole and not stuff them, because I thought it was difficult to overlay the flaps without any kind of support. So we this just overlay them over the macular hole to remove the PFCL, put in gas as a tamponade. This was what I had routinely doing, and almost more than 95% of my macular holes used to close using this technique. We became so this patient 6 weeks post-op, you can see a good closure. The patient's vision had improved, and I was so confident using this technique. Even like these giant macular holes, something like 1800 micron hole, I did the same follow-up, same technique, just overlay the flaps over the macular hole. I think you have time? Yes?
You have a minute.
Okay. And again, the wide ILM peel, and then PFCL bubble to overlay the flaps, and then again do a gas tamponade. And this is 3 weeks post-op. The patient's hole had closed. Such a giant macular hole we were able to close, and the patient's vision had improved to 6/36. But at this point of time, I started missing things in my operation theater, and that's why I titled this talk as Misadventures in Macular Hole Surgery. And the first miss was the gas. When we ran out of the gas during the surgery, completed, my assistant just told me that we have ran out of gas, so what to do? And I thought, like, okay, Dr. Klaus Eckhart used to say only air is enough because the macular hole closes 1 day post-operatively. So I just fashioned the flaps over the macular hole, and then did a fluid PFCL exchange, and then just left the patient on air. We closed without the gas, and this is 6 weeks post-op, ILM peel plus flap plus PFCL plus air, and this is macular hole is closed, 6/12. No gas was used in this patient. The second miss was I missed PFCL now. So this was like a patient with dry AMD and a macular hole, and I again started doing ILM peel, but then my assistant told me now there is no PFCL. You have been using too much of it, PFCL, so we have ran out of it. So you have to manage it without the PFCL. So then I remembered Sophia. She instead of using PFCL uses viscoat over the flaps. So in this patient, after doing a fluid air exchange, I put some viscoat over this flap to to stabilize those flaps, and then left it with air only, no gas tamponade. And this is 2 weeks post-op. Again, ILM peel, flap, visco air, the hole is closed, the patient's best corrected vision had improved to 6/36. Then the third miss was we missed air in this patient. What happened was, like, suddenly during the surgery I realized that my air pump is not working properly. My vitrectomy has failed me. And again we did PFCL, we fashioned the flaps over the hole, started viscoelastic injection around this PFCL bubble, slowly removed the PFCL bubble. From there I had no air to replace the PFCL bubble, so just visco over the hole, over the flaps, and then close the sclerotomies, no tamponade at all, just saline. And this is 1 day post-op. I saw the visco filling the hole, and then this over a period of 2 months, the macular hole had closed and the patient's vision had improved. This is 4 months, the patient's vision had improved to 6/24. Just ILM peel, flap, and visco. Then somehow I converted. I thought this is a very good technique. The patient next day, no positioning, nothing. So just next day is able to see something. And so I thought I'll just keep on doing it. We followed this technique for some 5-6 cases, but then I missed this. Then I got this patient where we missed success in this case. And again, you see, I just put some PFCL over the flaps. Then surrounding the flaps, I used visco. And
I think, can you summarize, Sangeet?
yeah, just one more case, last. So here, they removed the PFCL bubble and put some more visco, but the patient's hole did not close. But over a period of time, the flaps got folded and they went inside the hole, and then the hole was closed. There was patient's vision improved to 612. But now, as we discuss, we now think that this is the flap which is doing all the activity. The cases are being closed. But now the last thing we missed was the flap. So what we did here in this patient, there was a ERM, there was an ILM. I started peeling both the ERM and the ILM in unison. And when I tried to take out trim the flaps, the whole of the thing came inside the cutter only. And in this patient, I tried some residual ILM from the sides to try to bring it in, but again, the flap was lost to the cutter. And but there was some kind of epimacular tissue which was present there. I just used viscoelastic to fashion it over the hole, and this is one day post-op, the patient's hole had closed. No, nothing, just viscoelastic over that epimacular tissue, no flap, no tamponade, and the patient's vision had improved to 6/18. And over a period of 2 months, the patient's vision had improved to 6/9. I would like to show this case, but due to the paucity of time, I did not. And so still, we don't know what is working in this macular hole surgeries.
Which brings me to the question that, before the flaps started, when the Kelly Wendell, you showed the whole history, we were already closing holes at 70 to 80%, and then once ILM peeling came, we were closing 90 to 95%.
Yes.
So which is the variety of holes where all these inversions and all these help? Because these days I see that people are doing these for every kind of macular hole. So we were already closing them at 95% just with an ILM peel.
Yeah. Yes.
So it's only the size or variety. So that's what I would like you to highlight.
Yeah, I think that's a very good thing that you highlighted, because the whole point of this presentation was like we are overdoing things nowadays. In many of the cases, like in 90% closure rate, we generally used to get just with the ILM peel only and no flaps.
Yeah.
So flaps came later. Instead, in fact, Dr. Jerzy Navrocky, when he introduced, was for the larger macular holes only.
Yeah.
And what I in my practice, what I have done is I've done a retrospective analysis of my cases, and out of those cases, what we have seen is like if your tractional hole index is less than 0.6, that is in my hands. It may be variable for others also. In literature, it has been described as less than 1, but in my hands it is 0.6, or the macular hole index if it is less than 0.3. Those holes don't close without the flap. Those holes need a flap to close them. I think I advise everybody to do a retrospective analysis of their own cases and see what is the best for them. As far as the baseline diameter, we did not find any significant correlation with the baseline diameter.
And as far as using the adjuvants like amniotic and all those, you restrict to these extremely large ones and myopic ones?
Adjuvants, I generally restrict myself to patients who had already undergone an ILM peel earlier, maybe in persistent macular holes, or maybe sometimes in macular holes with an associated RD, where again we have already done an ILM peel. We don't have any tissue to plug the holes in those cases.
Any
questions?
Sir, does usage of viscoelastic cause any IOP related fluctuations?
No, it's just a very small amount, does not cause an IOP increase.
Or even any...
So what we are using is the viscoat, that is a dispersive viscoelastic. Again, the incidence of IOP rise with it is very low.
So I have the second question, sir, that I've used the methyl cellulose. It kind of wash offs with the saline. So how do you keep it in place? Do you use a Helon, or is there something else?
No, the Helon won't stay there because it's cohesive viscoelastic. It will just float off. Again, methyl cellulose has the same problem. It will just float off. So you have to use a dispersive viscoelastic. What we are using, as I told you, is a viscoat.
if we think about the visual outcome, what you see in vitrectomy, a simple ILM peeling except some without flap or all technique is always better compared to what you do flap or you stuff inside. Because many a times we see that when you stuff inside or something, that has some kind of unpredictable RP atrophy. Many a times you are not stuffy inside, but you may end up RP atrophy. And when you put a viscomat also, the viscomat, that pressure also push that ILM to be inside the hole. And many a times you do see that kind of RP atrophy, and you can't get those visual outcome. You can't get the 6, 9, and 6 kind of vision, what you see in the simple ILM peeling. So I think if the hole size is smaller, better to do just vitrectomy, ILM peeling and gas, rather doing flap.
Yes, I totally agree, because but still what I feel is no stuffing, that is now proven. You don't have to stuff anything inside the hole until and unless you just need a closure, you don't need any vision, you can do that. You can overlay the flaps over the hole, and if you have overlaid and then you're putting viscoelastic or you're putting PFCL, I don't think that then it matters most. But if you're not overlaid it properly and you try to stuff it, then I think there is a problem.
Thank you, Sangeet. With paucity of time, we'll shift to the next talk. Thank you for all the...
Thanks a lot.
Dr. Dhanashri, please. I must also congratulate you, Sangeet, on preempting the closure of Strait of Hormuz and be prepared for no gas eventuality.
The massage.
Yes.
Nothing, I can switch it. Yeah. A very good afternoon to the invited faculty, our mentors, and probably the next gen brightest mind of ophthalmology. It is said that eyes are window to the soul, but for retina surgeon, eyes are window to the body. You can see what is happening in the brain, you can see what is happening in the vasculature, and you try to treat those patients accordingly. Over the years, we have all seen retina in different ways. When a decade or 2 decades before, it was the structure and function. Now with the newer diagnostic, it is at the microscopic level. The surgeries have also become refined. And with this quiz, we have tried to inculcate all of this into a small bunch of 35 questions and answers. At the outset, I'd like to thank the executive committee of VRAG for allowing us to be on the podium to conduct this session. For the questions, we have got a lot of input, and I would like to acknowledge some of the executive committee members, Dr. Kartik, Dr. Yogesh, Dr. Yogya ma'am, Dr. Rekha, Dr. Madhvi ma'am, and my partner in crime, Dr. Ruchi, for bringing the whole quiz together. What I would like to say is enjoy the event. The prizes are just for the postgraduate students, but everybody would be more insightful after the half an hour of quiz. And we feel that this is just the beginning of a new kind of entertainment plus knowledge combination while the meetings are on.
Hi, good afternoon, everyone. So we're going to go through the instructions. So this quiz, as said, is open for one and all. And we have 35 questions divided. And the questions will be from funders, diagnostic dilemmas, management, systemic connections. And remember, residents, the speed is crucial because accuracy is paramount. There will be no negative marking. So think fast and trust your clinical training. In case of a tie, the fastest finger first wins. And for all the delegates, think of this as a quick revision. And to our postgraduates and fellows, the winners will walk away with prize and prizes, but all of you will walk away with better insights into the retina. So without further ado, let's bring the fundus into focus. Everyone ready? Let the retinal battle begin. So first, how to set it up in your phone. There are some of the instructions. This is a QR code. So kindly scan through this QR code. Are we good now? Okay. So once you have scanned this QR code, it will ask you for your VRAG login and registration, which already has been sent to your phone, through which you want to do the previous one? Okay.
So OTP will come on the WhatsApp itself.
Yeah, so once this login is entered, you will get an OTP on your phone. Once an OTP comes, you have to enter the OTP in this. And once you're logged in, you'll see 3 lines. And from there, you have to click and select quiz. Can you see the quiz options? Yes, it's scan it. For people who have not been able to scan the QR code, we are just doing it for the last time again. If you all can scan the QR code.
The OTP will come on your WhatsApp. It will come.
Yes, the OTP is coming on WhatsApp.
Na jaiye.
So once you're on the dashboard, click on the 3 lines there, select quiz from the menu.
But what's it?
Yeah, so those of you who are not receiving the OTP, there's a master code which is 998877. You can enter that. This is an alternative way for those who have not received the OTP yet. It's 998877.
Okay. Have you logged in, everyone? Okay. So once that logged in is there, you can, on the menu, you can select the quiz option. And once you select the quiz option, here you can see questions with 4 options, and you have to select one. The question will be displayed on your phone with the images with all the 4 options. It's an MCQ-based question. So you have to select. And for each question, 30 seconds will be given. After 30 seconds, we'll be switching on to the next question. And on your phone also, the question and answer will disappear after 30 seconds.
Let's have a trial.
Yeah. So, try question.
Trial.
Okay.
Okay, so is everybody set or somebody needs more time?
Set. That's okay.
So
it says waiting for the quiz to start.
Is everybody in?
Yes.
How is the Josh?
Yes, sir.
Let's start.
Yo.
Oh. So this is a sample question. All are common symptoms of retinal detachment except field loss, flashes, floaters, and funny faces.
We are not getting the question or the answer. So where do we click? We click on live quiz or real time?
This is just to show how the questions and answers will.
Okay. One more. The visual acuity of a normal eye expressed in megapixels. 256 MP, 576, 128, and 1024.
Answer.
576. Human being has yet to make a camera which is equivalent to eye. Though the macular resolution is just 8-9 megapixels, when you combine bilateral with the peripheral, the resolution goes this far.
Join now. Join now is awesome.
Done?
That's automatic research.
Are we good?
So on your phone, just.
So we are now to the first question.
Where do we press? Live quiz?
Join now.
No, there is no join now.
Okay.
Yeah, no.
It will come. It will come. Give a couple of seconds.
Should I start?
Okay. So this is the first question.
No.
Yes, it's here.
It's coming.
Wait a couple of seconds.
Yes, 28 seconds left.
Okay.
Yeah. So the World Health Organization definition of blindness in visual acuity of less than
30 seconds time and exposure.
shiny.
Next. Retinal differentiation begins at
I am seeing some photoreceptors sparkling. Somewhere they are sparkling.
Answer to it. एक क्वेश्चन में आंसर क्या तो रिजल्ट आवे पर आंसर तो को
next.
Okay. A 35-year-old female presents with sudden onset paracentral scotoma in one eye, diagnosed with AMN, has least likely association with
Okay, was this? Was he explanation to us?
See that change? Did okay. Next.
If you want, I can.
Which layer is primarily affected in cotton wool spots?
V-scan feature best differentiates RRD from PVD. That is number 4.
Mismatched question.
Okay, so just leave that.
Okay.
Yeah.
Which B-scan feature best differentiates RRD from PVD?
0 seconds left. Next.
We can redo it if the question has not appeared. But I'm having questions.
This is 5.
Don't have to do it.
This is 5. Which layer is primarily affected in cotton wool spots?
Yeah. So from now on, as told, I'll just point out at the answer once the time is over.
But then you might lose time for the second question.
No, it's just before I change, I'll do it.
And next. And
okay. So the answer is C.
Everything is true regarding the 4-2-1 rule in diabetic retinopathy except below.
Oh, lama answer है यार. 25 सेकंड दईये सर.
पण वो obvious છે answer.
But answer what कर? Obvious.
This is just to make things clinically relevant.
Next.
So the answer is D. Okay. Okay. In addition to inhibiting VEGF-A, faricimab additionally works on
next student lane based on it has
which is not recommended in treating diabetic macular traction.
What not to do is also important equally. That's why this question has been set, because it is becoming left, right, and center bread butter for everything.
Next.
In V-scan ultrasonography, a longitudinal scan has been oriented. Beam or scan. Beam oriented.
Next. A 60-year-old presented with sudden flashes and floaters. On kinetic V scan, it shows significant mobility with persistent undulation. What is the diagnosis? Actually, uptight, right?
They have done it wrong.
Hi, 60-year-old વાળો જ આન્સર આપવાનો છે. Next.
Screen ના જોવો, mobile
Link of rules is used in RRD management too.
resident mobile में change करा. Link of rules so link of.
Yep. What is the change?
Get audio.
Change. You change whatever breaks. Yes, sir. Next. Which finding is seen in long-standing RRD but not in acute RRD? It's okay, we can split it.
So the enthusiasm has to come from Madhvi ma'am. After so many years also she is wooing for fastest finger first.
Next.
Silicone oil in the vitreous cavity most commonly induces this type of refractive change.
Yeah, that's your body.
Yeah, then so this is a roller coaster. You are going to pass through nooks and corners from center of the retina to the periphery.
Next. Which statement is false regarding IOL calculation in silicone oil-filled eyes?
Hola, Ashish. આ તો તારો આવ્યો.
So that's why I was telling this is a roller coaster from down to the top of
It's such timing.
Next. Which retinal lesions do not require prophylactic barrage laser before refractive or cataract surgery?
Very nice.
We have tried to make it slightly more clinically relevant as well as theoretical. So you will have all kinds of questions. Hope that solves the purpose of giving you better insights as well as invoking your brain cells to go in your past and try to tickle them while you are postgraduates for the consultants also.
Next.
Next question. Retinal exposure to green laser during photocoagulation induces a unique temporary color perception. This color was recently named. After 30 seconds.
Next.
ના પાડી
ના પાડી
મેડમ ના પાડી Which FFA phase shows laminar flow in the retinal veins?
Let's just clear.
Yeah, yes.
Take charge of the camera.
Section.
Next question.
That's right. It's not moving. So the processor of the system is also getting rebooted after 17 questions.
Okay.
That's it.
So,
Next.
yeah. How is dye pulling distinguished from leakage on FFA?
My face have badly twisted it. It and swimming. When I think I went to go try the direction, but you don't say twisted. It got for big.
Next. A petaloid pattern of hyperfluorescence in the FFA phase is typical of later. This is a merger of anterior segment and posterior segment.
Sure, next question.
Next.
On FFA, which criteria defines ischemic CRVO?
Madhvi ma'am is just getting rebooted now. She started her marathon, now it is, she's on her pace.
Sounds like so didn't get it to visit. Next.
Next. Yeah. High internal reflectivity on A scan with a wedge-shaped lucent shadow on the B scan. Most characteristic of.
Just
Next.
Next question. 100-day glaucoma NVG after ischemic CRVO typically develops within how many months?
This is a freebie. Common sense is the rarest sense. That's what common sense is the rarest sense.
What's tips? It's that just great.
Next. A 10-year-old presents with bilateral visual loss and a yellowish spot on the retina. Which history is most relevant for the diagnosis? So that's why I told the roller coaster will move down, take a twist, go back to where it was. Next.
The dosage of dexamethasone in Ozurdex implant is?
All helpline expired. Okay.
There
you go. Next. Yeah. A 60-year-old male treated elsewhere with choroiditis for 6 months, multiple yellow subretinal lesions seen on OCT as leopard spots. Which investigation will clinch the diagnosis? Okay.
Sure.
Next.
A 12-year-old child presents with bilateral loss of vision. Which history is essential to confirm the diagnosis?
What's that? Next. In which condition hydroxychloroquine is not used? By the way, this is an image of a saucer-shaped defect on OCT. Typical HCQ toxicity.
Sure. 27.
Next.
Which condition does not show the double layer sign on OCT?
Seven more to go.
Next.
A 30-year-old male with low-grade fever, fatigue, and night sweat presents with the findings shown, which is the treatment of choice to treat the condition. I am seeing a wry smile from somebody who has given the inputs.
Should we change the answer?
Yeah, I thought I'm going to call it. Next.
The smokestack pattern on FFA is pathognomic for
This is a breather. क्विज नो एक रूल है, the dumbest person is the quiz master. The lady is always wise. Next. Which imaging modality is the gold standard for monitoring the area and rate of geographic atrophy progression?
next.
Next.
In neovascular AMD, tachyphylaxis refers to
Again, because it is becoming left, right, and center. What to do, what not to do, and to stop. Next. The pitchfork sign on OCT scan in CNVMs is not secondary to or not seen in one of the following. So it's it's not seen in. It is not seen in. I'm just repeating it. Kindly pardon with the spell check here. Not seen in. Next.
a 38-year-old male has 7 days of blurred vision. Amsler grid shows a paracentral scotoma. Finding shows a yellow-white lesion superior to the fovea. What is the least likely association for PAM?
This is 0 second. Yes, good. Let's help you. That's good. Yeah. Next, see. Back to us.
Yes.
Next.
Alas.
As per BVOS, the grid laser photocoagulation is indicated in BRVO in following condition. Yeah,
Pretty questions.
even something different.
Check करूँ 10 questions नहीं है same नहीं है.
तू बदले તું જ બદલે
સર સાચા પડ્યા છે ને બસ
મારી પાસે બધા આન્સર છે મને યાદ પણ છે કોઈ અત્યારે પૂછશે બધા આન્સર આપીશ ડોન્ટ વરી
Okay.
એક્સપ્લેનેશન સાથે આપીશ It
Very
won't
fine. I
be
think we are done with the
basic.
questions.
So that's it. I hope everybody enjoyed.
answers.
We are giving you
Yeah, so a big thank you to the team because this was our and their maiden venture and they have made it possible. Thank you to the Aditech team.
You want?
No, actually, a big thank you to all of you. When I floated the idea first, I think big thank you to Madhvi, who immediately said that I will entrust this job to Nishant and his team.
So
This is the leaderboard.
Stick job. Hey, there, chalo. Pass.
Yeah, all of us. Can you scroll it
The
down?
student leaderboard.
નીચે જ જુઓ હા એ જ બતાવો ને ઉપર બતાવવાનું જ નહીં. સોનાલી રાજ.
Sonali Raj.
Please come.
Then Namrashi Ostwal.
1 second.
And Vaibhav Panwar.
1 second. We need to announce that apart from doing the quiz, Nishant is dedicating the quiz to his father, Bipin Kaka, and the prizes are from him. So, therefore,
Big thank you to Nishant
and his team. And also, consultants don't get prizes.
Yes.
Only students do.
And most importantly, the prize that he has chosen.
So the prizes are 28D, 2.2D and 20D. So I hope that when you go back, you all would examine the retina with your indirect and maybe this would give or make you a better person to treat them better.
20, 28, 30. 2.2, 20, 20.
So I would request Madhi ma'am to give the third prize. Vaibhav Panwar. A big round of applause. Knowledge is always power. Though when you use it with wisdom, it will work magic.
What is she?
Alai sir.
She was.
You can introduce yourself.
Jamnagar.
You can.
I just recently completed this. My PG just recently completed. I have come in Jamnagar.
So big round of applause for Jamnagar Medical College. Dr. Namrashi gets the second prize.
I'm Dr. Namrishi. I'm third year resident in MNJ Institute of Ophthalmology, Ahmedabad.
Yes. And the winner is Dr. Sonali Raj. A huge round of applause. Dr. Ben. So when I started my retina fellowship, my sir told me that a normal ophthalmologist would see through the vitreous, a retina surgeon would see the vitreous. That is the only difference. I hope that from today onward, all the PGs start seeing the vitreous rather than passing through the vitreous.
Just below.
I'm Dr. Shunali and I'm also from Jamnagar MP Shah Medical College. Doing my third year residency.
Sorry. And so,
બધાને આપાશ
હા તો ફટાફટ તું એક ફટાફટ જસ્ટ એક લોકોને જાણવું તો પડે.
Yeah, definitely. ના we'll start from here now. Leave it. આપી દો ને. I'll give the answer from here, not required.
Fast એકદમ.
So this is 3/60.
પછી
this is 8 to 10 weeks. This is diabetic retinopathy. This is nerve fiber layer. This is D, surgical intervention. This is A, no points guessing this. This is C.
C.
This is B. This is B again. This is melanoma. Choroidal melanoma.
That's okay.
Okay.
Jawab bol.
Posterior vitreous detachment.
Hello.
This is attachment at optic nerve head and ora serrata.
Yes.
This is determine the likely location and primary break. This is intraretinal cyst and a demarcation line. This is hyperopic shift. This is just a small tweak. The wrong answer is D, but it is measured in axial length into 0.7 rather than 1.7, 0.17. That is the correct answer is measured axial length into 0.7. This is C, asymptomatic lattice, pigmented lattice, and atrophic holes. This is OLO. They have created an artificial retina in vitro, and then they have tried to find out the color, the frequency, and they have named it OLO. This is the early arteriovenous phase. This is short posterior ciliary arteries. This is it. It fills a distinct anatomical space with fixed borders. Cystoid macular edema, more than 10 disc diameters of capillary non-perfusion, 3 months. This is exposure to laser light. Nowadays, every child is moving around with a light in his hand. This is 700 microns. This is MRI brain. We already had a case in the morning. Madam showed it. Lymphoma. No, that is fine, but out of this, people have to think laterally. Out of this, the closest option.
This closest.
This is radiation to the brain. This is hay fever. Actually, the correct answer there is Q fever. It is used in Q fever and all the remaining cases. This is myopic maculopathy because basically it's a pachychoroidal disease spectrum. Any kind of pachychoroid will have this except myopia. This is anti-cox therapy, a classical tubercular granuloma. This is the CSCR. This is fundus autofluorescence, again something which is forgotten but still important. This is diminished response to anti-VEGF after repeated use. Again, this is all inflammatory. CNVM will have this. So the wrong answer is ARMD. Thank you.
Question.
Yes.
Fantastic job. Fantastic. Very, very good job.
So now we invite Dr. Maitri Jain for her talk on genetics in retina.
So this year we thought that we'd have something new, which would interest us all, and something very futuristic. So this is the first thought that has come, and every year we will have a new thing, which is going to be the future in retina. So I'm sure you can predict what is going to come next year. But this year we have Dr. Maitri, who is a consultant genetic counselor, and she's going to enlighten us about how we can use genetics in retina, which cases, and where we can get these tests done, and how is it useful. And she's a genetic certified counselor with more than 5 years of practical experience. And she'll be speaking on molecular diagnostic and genetic counseling perspectives of genetics in retina. Dr. Maitri, please.
Hello. Very good afternoon to everyone present here. I sincerely thank Dr. Alay Banker sir for giving me the opportunity to speak at this coveted forum. And the topic that is assigned to me is genetics of retina. So as clinicians, I know all of you must find genetics pretty far-fetched and boring, and sometimes with limited clinical implications or applications in the management of the patient practically. But I hope with this talk and with the cases that we'll see, you are able to change your mind and you find it interesting and informative, and maybe introduce the use of molecular genetic testing in some of your relevant patients. So let's move straight into the topic. So inherited retinal disease, we define it as a group of genetically and phenotypically diverse disorders that are rare. So this is the first point, that they occur 1 in 2,000 to 3,000 people. And they are often progressive, with the exception of a couple of conditions like achromatopsia or congenital stationary night blindness, in which they are pretty stationary. And these disorders are caused by alterations or mutations in genes that affect the retinal cells, basically, and leading to significant vision loss or blindness. There are more than 250 genes that have been associated with this condition, and more gene discovery keeps on happening every year. It accounts for 5 to 8% of all blindness and 10 to 15% of the retinal disease burden, actually. It is one of the leading causes of irreversible blindness in children. And in the UK and in many other countries, for working class adults as well, it is one of the leading causes of low visual acuity. So this is actually a very landmark publication in ophthalmology, published in the year 2017, in which Dr. Edwin M. Stone and his team from the University of Iowa, United States, they have conducted the molecular genetic testing of 1,000 plus families. And in each family, there are a lot of individuals that are affected with inherited retinal disease. And with this, they have come up with a really interesting way of classifying the genetic retinal disorders, as well as a lot of interesting data has come out of this paper and publication. So the most intuitive finding is that non-syndromic retinitis pigmentosa actually accounts for 34% of all IRDs. That is almost more than 1/3. And the second most common disease is autosomal recessive Stargardt disease. So if you know about these two diseases in detail, then actually you are covering more than 50% of all genetic retinal disorders. So when should one suspect a Mendelian retinal disease? So by Mendelian, I mean discovered by the scientist Gregor Mendel, who came up with the idea that alteration in genes are passed on through generations in particular patterns of inheritance. So when should you suspect this patient may have a genetic issue due to which they are facing this particular visual problem? So these are some of the main pointers for that. So early onset, presenting usually before the age of 40, all IRDs, and in some cases, of course, like in Leber's congenital amaurosis, they present in the first few weeks of life. The issue is usually bilateral and symmetrical, so you see usually a mirror image kind of a picture in many cases. It is slow progressive, unlike many other cases of inflammatory eye disease, etc., in which the progression happens in weeks or months, but here it takes years for the defect to progress. And then there are certain pathognomonic signs in the retina in the fundus that you see, like pisiform or yellow flecks in Stargardt, or vitelliform lesions, egg yolk type lesions in Bessel dystrophy, or the classical bone spicule, black lacy pigmentation, retinitis pigmentosa. And then probably, of course, the most intuitive finding is that you see a positive family history on either the maternal side or the paternal side with some similar presentation that would just alert us towards something genetic going on. And other organ involvement. So usually 15 to 20% of all genetic retinal diseases are syndromic, and they have involvement of other organ systems apart from the eye. So if any of these points are there, we should suspect that there might be a genetic issue. So regarding the publication that I showed a slide before this by Dr. Stone's team from University of Iowa, and they came up with this Iowa classification of inherited retinal disease.
And so this is just the different layers of the retina that are shown from bottom to top. We see from the inner to the outer layer, the neuronal layer, the photoreceptors, the retinal pigment epithelium, and the choroid. And they came up with the idea that depending upon the anatomical location of where the defect is, we classify them into 3 categories. So first is photoreceptor disorders, which are in which the pathology lies in the rods and the cones. Second is macular dystrophy, in which the defect lies somewhere between the photoreceptors and the retinal pigment epithelium in the ellipsoid zone. And then everything else belongs to the third branch disorders. So percentage-wise, if we see, again, majority, 2/3 are photoreceptor diseases, 28% is macular dystrophy, and a small portion is attributed to the third branch disorders, which includes where the pathophysiology basically lies somewhere superior or somewhere deeper. So as we discussed that 2 disorders, Stargardt's and non-syndromic RP, are accounting for 50%. And when we talk about 14 common genetic conditions, they actually account for 87% of all inherited retinal disease. And let's see them briefly through the same classification which we saw. So in photoreceptor disease, the first question that we ask is whether it is syndromic or non-syndromic. So the most common is non-syndromic, but in syndromic, the most common 2 conditions are Usher syndrome and Bardet-Biedl syndrome. Usher syndrome is what we know as deafness plus RP with different types. And Bardet-Biedl syndrome is another kind of ciliopathy in which there is polydactyly, opacity, and intellectual impairment. And oftentimes, these patients have come operated with the polydactyly, and you just see a scar on the lateral aspect of the hand. So if there is some cognitive disability that you see in the patient, young patient with RP, with the history of polydactyly being removed in the future in the childhood, we should suspect Bardet-Biedl. There are many other syndromic associations, but these 2 disorders, they make it to the big 14 list. And then when we talk about non-syndromic, the next question we ask is whether it is acquired or congenital. So if the issue started after the first birthday of the child or before. So if it is congenital, the most common 4 disorders that they have listed according to their data is Leber's congenital amyloidosis, achromatopsia, and severe early onset and early onset retinal dystrophy. And in the acquired, that is the symptoms begin after the age of 4 years, maybe in the late childhood or adolescence or adulthood. The next question that we ask is whether it is rod-specific or cone-specific. And rod-specific diseases are actually 7 times more common than cone-specific genetic retinal disorders. Within retinitis pigmentosa, if we see, almost 1/3 are sporadic with no genetic cause identified. The other 1/3 are autosomal recessive, and the other 1/3 is attributed to autosomal dominant and X-linked disorders. So even with or without family history, if you see an RP patient, there is 60 to 70% chance that you will find a genetic mutation in some or the other gene that may be hereditary. In macular dystrophies, as we saw, the most common is Stargardt, followed by West disease and pattern dystrophy. And in the third branch disorders, we have diseases apart from the photoreceptors in the macula. So here we have choroideremia or choroidopathies, which also include many other disorders. X-linked retinoschisis, in which there is splitting of the inner retinal layers. Dominant optic atrophy, as well as Leber's hereditary optic neuropathy, LHON. And other categories like retinal tumors, retinoblastoma, von Hippel-Lindau syndrome, and tuberous sclerosis syndrome have certain tumors in the eye. And since I work closely with hereditary cancer patients, we often counsel families and patients affected with these rare retinal tumors. Then the next category is Vitreo retinopathy, in which you see Nuri syndrome or Stickler syndrome, etc. Oculocutaneous and cutaneous albinism, and foveal hyperplasia. So this is just the basics of, I just thought you might find it interesting, that this is just one way of classifying these disorders, but in this you include a lot of diseases. So let's quickly move on to a few interesting cases now. So this is a young couple who came to me since they were wanting to plan for a child. And the issue was that the husband over here, so he's a 31-year-old male and he had complaint of night blindness since his teenage. It was a slow progressive peripheral vision loss that he faced with some blind spots. And he was diagnosed with atypical RP. He had thinning of macula with disc being normal. And his ERG was also showing the absence of scotopic plus photopic responses. The family history was pretty significant. And this is the family tree. So as genetic counselors and clinical geneticists, this is something that we do for every patient is note down the family history. And here we can see that the squares represent males, circles represent females, and we see the 3 generations over here. And in each generation, the siblings are connected by the vertical lines and the spouses are connected by the horizontal lines. So here we see our index patient is in the 3rd generation, the 31-year-old male. And his mother and father are normal, but his maternal grandfather is affected. Maternal grandfather's all brothers are affected. And one of the maternal grandfather's son is also affected. So the same presentation of night blindness and tunnel vision beginning in late childhood or adolescence, and then they are all in their older ages, but they are okay, they're still doing okay. So with this particular case, now they wanted to have a healthy child. So we went ahead and did a genetic testing for this index patient. And we found out that he has a hemizygous pathogenic mutation in the CHM gene, which confirms the diagnosis of choroideremia. So we were anyway suspecting an X-linked condition since there are only male members that are affected, and they are connected by unaffected females, as we can see and there is no male-to-male transmission that is happening. With the help of this diagnosis, we were able to give a prognostication as well. Choroideremia has a bit of a slower progression than RP, and the central vision is preserved till older age as compared to classic RP. So that reassurance could be given to the patient. As far as gene therapy is concerned, it is currently under phase 1-2 clinical trials in which CHM gene deficient genetically confirmed males are being enrolled. And gene replacement for the same using intravitreal delivery is being conducted currently at Salt Lake City, Utah, as well as in Texas. And it's a very promising trial, and the results are supposed to be out in the year 2027. So this much information we could give to the family. And their main concern that they wanted to have a healthy child, we could address that as well. So this is basically showing that his mother is likely to be a carrier. And hence, he's getting his Y chromosome from the father and the X chromosome, which is the affected X chromosome from the mother, and hence he's affected. But when he himself plans for a child, considering that it's very less likely that his wife is a carrier, there is 100% chance that his children will be normal. Why? Because his sons, he will pass the Y chromosome to the sons, so sons will be normal. He will pass the X chromosome to the daughters, but the daughters will only be asymptomatic carriers. So all his children are likely to be normal, and he does not need to undergo any other investigation further now. So this particular case just helps us to highlight that. Let's quickly move on to the second case. This is of a 7-year-old female. Complaint of poor vision, difficulty in reading and recognizing new faces, no night blindness or photophobia, and negative family history. Here we can see 7-year-old child with a younger sibling who's 4-year-old, parents normal. This is the fundus, and here we can appreciate the dark atrophic macular patch as well as the whitish yellow flecks in the posterior pole in the bottom image. And given the clinical situation, we often suspect Stargardt's disease. And this is the OCT of the child. And here we see, I'm sure you will be able to appreciate it better, the foveal thinning as well as the loss of ellipsoid zone and outer retinal layers. So Stargardt's was suspected, and that is what we found in this patient. Confirmed diagnosis of ABCA4 related biallelic pathogenic mutation. So both the copies that she inherited from her father and her mother were aberrant, and Stargardt's type 1 was confirmed. Autosomal recessive condition in which parents are carriers, and 25% chance of children to be affected. So we counseled the family, and of course, as clinically indicated, helped them to use low vision aids like telescopic glasses, hand and stand magnifiers, and using electronic screens rather than books so that they can zoom into the device and help in reading. So one interesting aspect for this particular case and this disease is that vitamin A, which is the chemical that you people prescribe for blindness actually, is contraindicated in Stargardt's disease. So basically high-dose vitamin A supplementation should be avoided, and the basic reason lies in the pathophysiology of Stargardt's, that is the vitamin A-derived byproducts from the visual cycle. They lead to further accumulation of lipofuscin in the retina, and in this particular disease, lipofuscin clearance is affected. So that would lead to more and more accumulation, which would accelerate the retinal damage actually. In fact, a lot of small molecules and oral drugs are being tested, and this is one of the drugs, tinlarebant, which is received a breakthrough therapy designation actually, and it exploits the same phenomena, that it's to be taken once a day, and it prevents or reduces the accumulation of toxic vitamin A byproducts in the retina, and by reducing basically the active retinol entering the retina. And it has demonstrated very promising results, 36% reduction in the atrophic lesions in the retina of adolescents. And in the first half of 2026, that is this year itself, the company plans to file an NDA. For this family, again, if they wish to have another child, there are options of prenatal testing. So you might have heard about amniocentesis, which is a procedure in which amniotic fluid is drawn at 4 months of pregnancy, and that is used to send for the DNA testing. And if the same double mutation is occurring, which is a 25% chance, they can decide for the pregnancy. And similarly, there is a procedure called chorionic villus sampling, which actually occurs early on at 3rd month itself. And in the early pregnancy itself, the couple can come to know within a week after testing that whether their child is affected or not by taking the sample from the placenta. And in India, medical termination of pregnancy is legal till 6 months, that is 24 weeks. I'll quickly brush the 3rd case and then we'll wrap it up. So this case actually, it's an old case, and it was referred to me by an IVF center and an IVF expert. It's a 3 or 8 month old female born via IVF conception, and she has a twin sister as well. The twin sister is normal, but this child is having a lot of syndromic issues. So there is global delay, poor growth, poor tone, recurrent infections, middle ear infections, mouth sores, respiratory tract infections, UTIs, for which she requires a lot of hospital admissions. Poor vision is one of the features that the mother highlighted, that she is not able to see anything properly and brings all the objects close to the eye, but never been evaluated. And then issues with sleep, feeding, and other behavioral issues. She also has characteristic facial features. Now, as genetic counselors and geneticists, identifying facial dysmorphism is something which we are taught. And so this is the picture of the child, an old photograph. And here, I don't know, but the better, which we can appreciate over here, is that she has thick, bushy eyebrows, low-hanging columella, that is the tip of the nose or the beaked nose, prominent central incisors, a myopic hypertonic face, and low-set ears, that is ears below the eye line. So with all the combination of these features, we went ahead with the testing, and it confirmed Cohen syndrome in the patient, which is again an autosomal dominant condition. And it is one of the top 10 syndromic causes of RP. This condition particularly has a variety of features, and neutropenia is one of them. And that is why the child kept having repeated infections, and that has a specific treatment basically. And also in this condition, the patients usually develop obesity later on, and related basically complications of diabetes as well as hyperlipidemia. So the holistic systemic counseling needs to be done, and they need to be put on a surveillance protocol. This is also an autosomal recessive condition basically. And the reason why they had come for genetic counseling over here is that they were suspecting that since they had went ahead and did an IVF conception, this something wrong happened with their child, and it is the fault of the referring gynecologist. So then later on, we took a detailed history, and we found out that actually the wife's great-grandmother and the husband's grandfather were actually siblings. So this is a distant consanguinity which was proved on recurrent history, and that helped to reassure the patient basically that even if they had gone for a normal conception, there was always a 25% chance that this would happen. And the accusation on the IVF expert was basically taken care of, and they understood the case. And they also had frozen their embryos. So in case they plan for a second pregnancy or in the future, we can do what is now done at all major centers and major cities, is what we call as pre-implantation genetic testing and IVF for monogenic disorders. In this, the embryo is tested for a particular gene, and if it is present, that embryo is deselected and other embryos are selected. So this particular patient can benefit from this.
Okay, can you summarize?
Yeah. So I'll just skip this few slides for the sake of time. This is my last slide. Why get a genetic diagnosis? So very important. Better understanding of the disease and prognostication, as we saw with the cases. Even if there is no known treatment, just knowing at the molecular, at the DNA level, why this problem is happening, gives a lot of insight to the patient into their own disease, which they might be living with since years. And also prognostication. Ascertaining the risk of recurrence, only if we know the correct gene, will be able to tell what is the pattern of inheritance and what is the risk to the siblings or the children that are born, and how can we prevent them to come back into the next generation. Eligibility for gene trials, drug contraindication or indication. Oftentimes in inherited retinal disease, there is secondary inflammatory features that are resistant to the drugs. So to rule that out, if we do genetic testing and it's actually genetic, then the patient can be stopped on the long-term steroids and immunosuppressants which they otherwise are on. And understanding and managing the systemic implications. So, say for example, in type 2, type 3 ushers, in which FS presents later, if we find RP and if we molecularly diagnose them, then we can actually send them for genetic testing, and then later on to an audiologist, and at least deafness can be corrected at the right time, so that the patient is saved from double disability. So that's it. These are some of my resources, and I'm part of this ocular genetics interest group from Dr. Shroff's Charitable Eye Hospital, which is very insightful. Yeah, thank you.
Thank you very much, Maitri. I would request Dr. Madhvi to hand over a memento to Dr. Maitri. And while we are getting ready for a group photo, if anybody has any questions for Maitri while we get ready for the group photo, so we can save some time. I think one simple question: how much does it cost for a genetic test? I think that is what most people are interested in. And how is it accessible in Gujarat?
Yeah, so usually these tests cost somewhere around 15 to 20,000 per patient per sample. They are done on the peripheral blood, and it takes about 2 to 3 weeks for the reports to come. And in these cases, we saw that we got a diagnosis. Oftentimes, we get negative reports and uncertain reports as well. So that needs to be seen, and it is readily available in Gujarat, in Ahmedabad, Baroda, and all the cities by major labs. So basically in Gujarat, we have Supratech and Unipath, whereas there are other labs in Bangalore like Medgenome and Life Sciences, which are commonly offering these tests. And home collection is also something that they commonly do. So yeah.
Some of the online kits they are available. We can order it and they send the kit, and we have to send the saliva samples, and they'll
not the saliva samples, because we send usually the peripheral blood, because it is more DNA rich, and so that basically you can contact the lab directly and they can come for the sampling of the patient.
Okay. We do see retinopathy patients, so their family wants second child.
Right.
So in this case, so what would be the best approach for genetics?
So in bilateral RP, almost 100% cases are due to the germline RB1 mutation. But if it's unilateral, also according to the guidelines, we should send for genetic testing. Sometimes the parents are having silent features like retinal scars, which are not causing any vision issues, but it is actually autosomal dominant. So in the patient's future child, if there is a 50% chance that it can pass, and if the couple is planning for a second child, in that case also genetic testing for the parents and the child should be done, so that exact risk of recurrence can be given, and that can be prevented by prenatal testing.
In the as you showed on the IVF, can we do pre-implantation genetic?
Definitely. If the mutation is identified, then even if their fertility is normal, they can go for IVF for this particular reason, to avoid the genetic condition in the second child.
Thank you.
Any other questions?
Where do we get the whole genome sequencing?
Sir, whole genome sequencing is a test which is actually currently only used not in clinical situations, only in research, because we don't know a lot about the entire genome. So what we send for patients is whole exome or clinical exome sequencing, in which they test only the genes which are known to cause some or the other genetic condition, and targeted, and there are gene panels also, and they can be sent, as I told you, there are a lot of labs and a lot of players in the market. So for this period,
Goodbye Hospital in Ahmedabad have this facility. If anybody requires, please let us know. Genetic counseling and testing. RT passing test reports.
Any further questions? So I think Kushal, you'll have to instruct everybody to come for the group photo.
So before we start the last session, I request everyone to just join us on the stage for a group photo.
Make it quick, please. Otherwise, you'll have to go home late.
Sir, budget kursi, please. Sir, please. God, हमारी वेब चैट आ रही होता है Daniel बोले ना आपको everything in the place. It's that way. And it's like just can I answer people like that? It's trying to think something to do with. Where you were not says it. He said, "Hey, Chuck, it's busy." I myself. Everybody is talking about so you have to say so. I mean, where? Sit the way is that? Sorry. Basically, no, that's it. What's it? Is it? I guess it's it. That's fine. So they're getting the patcher. Right? You see that? That's what I'm saying. History. What's it? But I go for what? But God, it's a high level of something. Oh, my freaking the top. I'll take it. It's ancient. Okay, but we us. Look. At. You know, back. It'll tell that. Did it? What that? Although, bang that? No, nothing. Để con bạn đi ra được. Được. Theo được. Nhập nhập. Có đấy chứ. Trên đi chơi con đi trên này. Cái đi. Ở trên cái side. Để có biết đã. Sorry for that. Yeah, that was very quick. You might back it. You big. It does. How do Để xí đó nè. Xí đó. Yêu. Cái start with the channel. That is connected.
While we rearrange ourselves, we want to start our last session now.
The medical retina one. Sunflower. જે હતી ને black. 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 Yeah, speaker knows point. So for this session, we would like to invite on panel once again requesting Sangeet sir, Dhanashri ma'am, Kamar sir, Dr. Milan sir, and Dr. Anil Patil. You can be joining the panel for now. Manoj sir, requesting you to join the stage. So due to time shortage, requesting first talk from Dr. Samir Wankawala. Yeah. So he has some time constraints. So requesting him to start his talk, real world case presentation on Webismo.
So, good afternoon, everyone. Myself, Dr. Samir Wakala. I am a retina surgeon from IQI Hospital, Gujarat. So, I'm going to go through a quick, there are many of cases. I'm going to show OCT reports of my own personal experience with the real world experience with the faricimab. There is no financial interest in this. This is a case one, and the patient with the left eye has a history of hypertension, diabetes, on medication, and he has taken 6 injections before coming to my hospital, and history of PRP laser done elsewhere, diagnosed as a PDR status post PRP. OCT report suggestive of a cystic fluid and intraretinal fluids in the right eye of the patients. And 1 month after the injections, first dose, I can see the flattening of the retina, and there is sudden resolution of the intraretinal fluids, and I can see the retina asymmetry has started coming up. Again, the same patient has come to me. If I can see the date, he has come to me. The last injection was given on the 30th of December, and the patient has come back to me on the March 22nd. And again, the same problem. Again, the injection was given, and after 1 month, I can see the result, and the intraretinal fluid and the cystic retinal fluid has been started resolving. And again, the same patients. What I can see in after the multiple injection, the second injection was given 3 months after the first, and the third injection was given was almost 5 months after the second dose. So this patient was with the other anti-VEGF before, and after switching to Vabysmo, the duration between the injections has been increased a lot. Second thing which I have find out that the visual recovery has gained beyond anatomical recovery. So right eye of the same patients, you can see the large cystic intraretinal fluids, and after first injections there is a complete resolutions of the fluid. And again, after 3 months the patients come again, he has the same cystic fluids, and after 1 month again there is a complete resolutions of the fluid. And the same patients, the same thing. So what the similar results what I have seen is this, that it's identical to the right eye. The injection was given 3 months after the first, and the third was also almost 5 months. The patient has recovered very well, and patient is on follow-up. I think she was on follow-up since 6 to 8 months, and there was no more diabetic cystic fluid, and she was maintaining well. There's another case 3, a teacher by a professional and very poor on her follow-up. She is very much studious with her students, and a case of severe NPDR with the CME, and there is multiple hard exudate. If you can see in the OCT finding of the left eye, there are multiple hard exudate at the center of the fovea, and there are intraretinal fluids. There is a mild subretinal elevations Also, the first two injections was given at 1 month interval, and I can see the subretinal intraretinal cyst fluid has been starting resolving, and the hard exudate also starting compromising. Again, the patients after the third dose, if I can see the hard exudates, if you compare the first OCT report and compare the last OCT report, I can see the hard exudate has been removed completely. There are few hard exudates, but patient was maintaining well. This case suggestive of the hard exudates, the hyperreflective areas are reduced on follow-ups. Injection, her vision has been improved. So it has a very good effect on reduction of the hard exudates. The right eye of the same patients, also the same result. I can see on consecutive results, the hard exudate has been reduced after the 2 doses of the intravitreal Vabysmo. So this is a case, another case 5, the left eye, elderly lady with a hypertension, diabetes on the blood thinner. For interest of time, I'm not going through systemic findings. And if you can see on the left side, there are multiple area of the subretinal fluid, intraretinal fluid. There are hard exudates, and after each consecutive injections, there is a reduction of the intraretinal fluid and hard exudates and strengthening drops. The right eye of the same patient diagnosed has a PDR status post PRP. The similar findings, the patient has a vitreous hemorrhage also, hard exudates also. And after the loading dose of this, the patient has improved well and vision was improving very well. The case 7 of the 40-year patient diagnosed, she was recently a case come to me, and she has a case of BRVO with moderate NPDR, and I have diagnosed, I sent it to a physician, and then she has recently diagnosed as a diabetic mellitus, lipidemia, and hypertension. This is the first, after 1 month, the pre and post OCT, and the third which I have in my file, she has completely recovered with only the 1 injection. The case 8 of the left eye patients, this is a case where the patient has a neovascularization. If you can see, and the down to sum up, yeah. So you so this is one of the interesting case where there is a ERM and the intraretinal fluids, and again there is a subretinal detachment. After 2 doses, we can see there is a very smoothing of the fluids, and the ERM also has been reduced. The traction has also been reduced. So not taking a lot of time, and going for a very interesting case, the last one. I think this is a case, the patient has the retinal detachment in the other eye, and the patient came to me that my other eye vision is also has been reduced. This is the left eye of the patient, and we can see there is a pachychoroid and there is a retina excavation and the intraretinal fluid. The patient has given injection Vabysmo, and after the 2 doses, patient has completely recovered. So what my learning from the injection Vabysmo is, all other anti-VEGF, though have provided the visual gain and durability, the outcomes are not sustained over a period of time. So higher proportion of the patients are going into the non-responding and the recalcitrant stage. So faricimab is the stronger molecule, allowing the patients to take fewer injections with a higher disease interval, injection-free intervals. So starting early, it improves the functional and anatomical outcomes. The longer treatment interval will help the patient both financially and also physically. So achieving the vascular stability improves the clinical biomarker of the disease control and stability. So basically, these injections reduce the treatment burden and alleviate the clinical capacity. So thank you. Thank you very much.
Yeah, thank you, Dr. Samir. I think due to lack of time, we move on directly to the next presentation.
Thank you.
Dr. Rutul Patel, PAM, a stitch in time saves lives.
Good afternoon, everyone. Yeah, my topic for presentation is PAM. A stitch in time saves 9. Basically, I have chosen this topic just to emphasize more on preventive medicine. Nowadays, we are seeing many young persons facing cardiovascular events early in age or stroke or something like that. And there are few ways where we can, as a retina surgeon, can help detect these problems earlier. So the eyes are windows to the soul. These are the few findings in the eye which can predict the systemic problems earlier and can prevent them for future complications. So coming to the paracentral acute middle layer maculopathy, that is PAM, it is an OCT-based red flag for deep retinal ischemia. I'll start with a single first case. That is a 39-year male patient, had a dimness of vision in right eye since 1 month, and vision was 6/12 in right eye. Fundus was okay. There was mild grayish discoloration just nasal to the fovea. There was a patch of grayish patch. And in OCT, grossly it was normal, but if we see the hyperreflective band towards the nasal side, suggestion of the PAM. And then we advised some systemic investigations, a coagulation profile to be specific, and there were high triglyceride as well as VLDL found, and homocysteine was also very high, more than 50. So basically, what is PAM? So it's a multimodal imaging finding, which is basically acute hyperreflective band at the level of INL. And it was originally described as an subtype of AMN in 2013, and now it is recognized as a distinct entity, which is more, which happens in intermediate as well as deep capillary plexus. So coming to the pathophysiology of the same, as we know, ICP and DCP, they are watershed zones, because of that there is a lower oxygen tension, particularly in the deep capillary plexus, which is more prone to development of ischemia. So in the initial phase or acute phase of ischemia, there is an intracellular edema, which results in the hyperreflective band in the OCT at the level of INL. And if it is not resolved in chronic phase, it can lead to the INL volume atrophy and thinning of the middle layer of the retina. In symptoms, sometimes patients may face some kind of scotoma, a positive scotoma, as well as visual acuity can be preserved in majority of the cases. So it is very difficult to diagnose in early early stages without any OCT findings. Fundus may appear normal or subtle, and it may have some grayish white lesions, which is little less evident compared to the cottonwood spots. On OCT is the main key factor. In early stage, we can see the hyperreflective band in the inner layers, and in late stage, there is an INL atrophy. Octa shows some flow voids or dropout areas, specifically in the deep capillary plexus. The main differential is the acute macular neuroretinopathy, which happens in the outer retinal environment, and thinning of the ONL. Why it is important? Because it is associated with the systemic thromboembolic events, and normally it has connections with hypertension, carotid artery stenosis, sickle cell disease, or using of vasoconstrictors, as well as post-surgical hypertension. There are few articles which show direct connection in patients with isolated PAM having more chances of cardiovascular disease, stroke, and death. And here is also a case presentation showing ischemic cardiomyopathy, which was detected by PAM. Here a case where there was before CRAO, 15 days before the CRAO, the early change was seen as a PAM. So the management is the workup to find out the reason behind it and to control it. So this is also a case of 26-year male, which was just a normal routine preoperative LASIK evaluation, and we can see some areas of hyperreflectivity seen in the nasal side of the fovea. Also, that was lipid profile was altered. Similar cases in diabetic patients also. Yeah, this is a case where the untreated or the uncontrolled diabetes led to the INL atrophy in the later stage of the disease. So the take-home message is basically normal fundus is not a normal retina nowadays. We'll have to think out of the box when there is a complaint of scotoma, and patient has a scotoma. Even with 20/20 vision, we have to do an OCT and carefully see the OCT, because the PAM has some life-saving potential of detecting in early stage of any cardiac or carotid disease or the occult hypertension. Thank you.
Yeah, thank you, Dr. Rotan. It's a nice case. Nice cases regarding PAM. Anything about follow-up in these cases? Like, did you follow?
Yes, sir. Basically, it's very much reversible if the underlying systemic conditions are controlled timely. The vision and the scotoma, both of them are reversible. But if the underlying condition is not controlled, like in this case is diabetic patients or hyperlipidemia, then it leads to the atrophy of the INL, and particularly scotoma may persist for a longer time or vision may deteriorate further.
Most of these patients would be asymptomatic, right?
Yes, sir.
And it's an accidental finding, or?
Yeah, sir. In fundus, we may see a small grayish change if we look carefully. And otherwise, some patients, some conscious patients may present with some scotoma. They have complaints of little bit of scotoma. And particularly in OCT, if we see very carefully, we can find out this thing, PAM.
These findings are pretty common in CRAO cases, right?
Yes, sir.
So probably patients with transient visual obscuration, we can do on OCT and find such spot so that we can send for cardiac.
Yes, this is what I showed. One case where it was 15 days before the event of CRAO, they could see PAM in the OCT changes. Yeah, there was a flow void particular in deep capillary plexus area. It reverses, yes. Early stages, acute stages is reversible, chronic stage is not. Yeah. So nowadays we are seeing in more young patients also.
Have you seen regression follow-up of these? Any of these patients have seen that OCT has become normal?
Yes, sir. Yes, sir. Actually, I couldn't bring it here, but we have seen patients with even symptomatic improvement also. In scotoma also, patient is getting better.
Without any treatment, just
Yes.
in self.
So basic thing is once you diagnose this thing,
Yes.
you have to do cardiovascular evaluation.
Yes, the coagulation profile, 2D echo is also advisable.
Yes, thank you, Dr. Rutul. Now we move on to the next case. Dr. Keshvi Shah. Now you see it, now you don't. The curious case of subretinal space remodeling and waxing waning of fluid.
So very good afternoon to everyone. And my presentation is now you see it, now you don't. This meaning will be clear in the next few slides. I'm thankful to VRAG and my team at Netralia for the constant support. First, we'll delve into the case details. A 23-year-old male patient with history of blunt ocular trauma 4 years prior and presently coming with complaints of diminished vision. He had been operated for lensectomy and vitrectomy with silicone oil tamponade elsewhere 2 months back for lens subluxation and detachment. So this is on the day of presentation. The key findings are patient had BCVA of 6 by 120. Anterior segment findings were suggestive of aphakia with iridocorneal adhesions, but posterior segment showed a redetachment in the inferior part with presence of subretinal fibrotic bands. At this point, our plan of action was to plan for resurgery. But patient came back with sudden loss of vision over the next 2 weeks, and vision had dropped to 6 by 150. At this point, we noted that there was hyphema and severe ciliary congestion. Posterior segment view was hazy and obscured. Now, the plan for resurgery we had to put aside, and we decided to mitigate the acute inflammatory response with intervention of oral and topical steroids along with cycloplegics. So we called the patient for follow-up after 4 weeks' time. At this point, we were expecting the hyphema to clear, but along with that, we also noticed that there was disappearance in the amount of the subretinal fluid as well as disappearance of the subretinal band. So now it's no longer visible. The OCT at this time showed diminished subretinal fluid as well as better visual outcome. At this point, we decided that no longer oral steroids were required, and hence we stopped the oral steroids and we started taper of the topical steroids. Patient was called back for follow-up after 4 weeks' time, and at this point, we were expecting the crisis to be mitigated, but instead, now there is rebound. So now we see a new retinal fibrotic band along the infratemporal arcade and increase in the subretinal fluid, which is corresponding with the OCT picture as well. So now we were in a dilemma how to proceed further, whether to go ahead with surgery or to restart steroids. So I'll just quickly summarize the clinical picture. Patient presented with 6 by 120 visual acuity, drop due to the hyphema. On initiation of steroids, there will be treatment, and then later there is recurrence once the steroids were tapered. And when we look at the sequential fundus photos, we notice that the subretinal gliotic band, which was visible in the first case, it disappears, but it comes back again. So why this case is unusual? Because first of all, there are multiple things which normally we don't see. One is presence of hyphema in the eye already with silicone oil tamponade. Second is regression, and then recurrence of the fibrotic bands as well as the fluids. So as we see it, our hypothesis is that the waxing and waning of the fluid and fibrotic bands had a link with the systemic and topical inflammation modulation. There is dynamic subretinal space remodeling which happens. It's not a simple wound healing response, and all of this is extremely steroid sensitive, as we noted in our case.
And yeah, thank you, Dr. Kish. Any inputs? What you feel? Any angiography done for this patient? Was it a rheumatogenic RD or it was exudative?
Sir, initially patient was operated for reg RD. After that, we have not planned a FFA for this patient.
Because at least if break is closed, can we expect such kind of waxing and waning phenomena like with steroids? Any inputs?
Should there be? Fluorescein might have helped when there was hyphema, or maybe later on once the fluid had resolved and it reappeared. Why it reappeared? Fluorescent angiography might be optional.
It's just the natural PVR process which is happening slowly. And sometimes just giving the patients long-term steroids, whether topical or systemic, you see the resolution of the PVR and the fluid. So that's why people say that if you see such, beginning of a fixed fold or maybe a small subretinal gliosis, you should not rush into doing a resurgery. You can just give steroids, ask the patient to position, and maybe the process just quietens down, and you can have a persistent fixed fold and an attached retina also. Also, again, the location of the residual fluid or the fixed fold or the PVR, if it's slightly nasally, it's not touching the macula, maybe you can pull along for a longer time before just going into early intervention.
But there was a recurrence after this.
So this, if you see, the subretinal gliosis kept on increasing. First it was only infranasal, then there was a band, then the band came temporally across the macula. So the PVR process, if you see, it's gradually increasing. I mean, if you see this, then there
was an improvement with steroids, and but there was a lapse.
So that's what I'm saying. It's just if you give high dose steroids, the PVR process is going to come under control. But as soon as you lower it, it's going to flare up. So, I mean, these are very tricky cases, particularly if it's a one-eyed patient. I mean, we would not like to intervene early, and we find out ways how we can maintain a stable, relatively stable, maybe ambulatory vision.
Sir, I would like to ask one question, whether we would like to continue the steroids for a long time, even in the post-operative period, would that be required or?
Absolutely. I mean, that's what I said. Supposing if it's a one-eyed patient, there is an indolent subretinal gliosis or mild PVR, I would continue, and I like to use difluprednate quite a lot in these patients, just once or twice a day, and keep them long. Just maintain, check. The most cases will have a lower IOP rather than higher IOP. So giving them diflucor maybe for 1 or 2 years, I won't hesitate.
So oral steroids?
I would not.
And any role for steroid sparing agents, if not?
Not really. Not really. Once the PVR process has set in, there is not much you can do.
Thank you, sir.
Just to add on, we have been managing this case together. So the last visit, the fourth visit, post redetachment, I now tried again for the steroids, but it is not working. Now it is persistent redetachment only. So I have right now counseled for the resurgery. That's it. So far not, ma'am, because it was a case from the beginning as a traumatic cataract with an RD operated elsewhere. So yeah, maybe.
Fine.
Because there's obviously some indolent inflammation going that you have not put your finger on. Technically, an attached retina will not have PVR. Secondly, we look for, when it's not responding clinically, you're going to look for other things, and we know nematodes cause this. A dead nematode can also cause this kind of a picture. The band may not be a band, it could just be fibrin. It could be a protein reaction, that's why it disappears. So, and if you see, the vessels are not normal. There are like beaded vessels in the lower temporal periphery. We are missing something. Yeah, it could be a dead nematode.
Yep.
they can say still very much this even but there was then seek they make it wrong.
So there was a perisilicon blood, but everything got resolved with these steroids.
So I think now we move on to the next presentation. Dr. Mukesh Porwal sir, he will be presenting on breaking the barrier with brolucizumab.
Thank you, everyone. Thank you. Good afternoon. Thank you, Madhavi ma'am, Parth, Kushal, and Alai sir for an excellent meeting. This is a talk sponsored by Novartis, though all the cases are my own and the company has nothing to do with it. For the meeting. Yeah. As we know, brolucizumab was introduced in India in October 20, and about a year before that in the US. Initially, we used it only in desperate bad cases where repeated injections were needed and people were tired of giving injections. And from the beginning, the brolucizumab had an advantage that we could space out the injections, so there was no loading dose. And gradually now we give in a lot of naive cases. In fact, some patients who are chronic patients ask for it actually in the other eye also. Now straight to the cases. This is an interesting 78-year-old active surgeon who had a lot of treatment before in his only seeing eye. One eye was lost to neovascular exudative AMD long back, and he stopped responding to ranibizumab, which was Lucentis at that time, so long back. And left eye was getting regular injections about 5 to 6 weeks apart, aflibercept. And he did recover every time, but he needed injections all the time. And he was a bit tired of it. This was his right and left eyes. The right eye was atrophic, a lot of RPE atrophy. Left eye also had sick RPE with an occult type 1 CNVM with a choroidal cavern or gap with recurrent intraretinal fluid now and then, for which he needed injections. So the picture would become like this after about 5 to 6 weeks of aflibercept back in 2019. At that time, we got a supply of the first brolucizumab, probably before Paginex was launched in India. And he responded quite well when we started using it. And the good part is the interval between the injections where we were able to increase it to 10 to 11 weeks actually. So these are OCT angiograms showing the neovascular network responding to brolucizumab. And this is a recent photograph after 29 injections of Paginex over last 6 years or so. And he's maintaining 6/9 part vision and is operating at the age of 83 in his 40. I'll skip the second case. This is also a bilateral PCV, one old, one recent, and the recent PCV responded so well to brolucizumab that the patient wanted injection in the other eye, and that also responded very well, which has been proved in the Hawk and Harrier studies. Not only the AMD, brolucizumab is also used in DME. It has been approved. And in complex cases where multiple injections have been required, especially Ozurdex in steroid responding patients, brolucizumab is a good option to reduce the number of injections like this diabetic macular edema, which waxes and wanes. And this has also been proved in the kite and kestrel studies. So brolucizumab is a smaller molecule having larger concentration and greater efficacy. The question, of course, remains, what about the side effects or intraocular inflammation with brolucizumab every time? We have this publication in the Indian Journal in a big multicentric trial across 21 centers, where the intraocular inflammation in Indian patients have been shown to be much less than 1%, 0.71% to be precise. In my experience, few cases of vitritis, mostly asymptomatic, and responded to topical steroid. In the early days, I got scared of one case. I did a precautionary vitrectomy. It did well, but there is definitely more drying and a longer course of action, leading to lesser number of injections with brolucizumab.
Well,
thank you very much.
Yeah, thank you, sir. Any question? Yes, with this.
I have some more cases, but due to lack of time, I've cut it down. Yes, this Dr. Ali. Shish.
I dare not speak in front of the capital of Pagenex in India, Rajkot. Just to say, I have seen dreadful cases of side effects of Pagenex from Rajkot, from all surgeons who have given. So it's not that it is not there. And it's your worst cases never come back to you. They always go to the others. So similarly, my cases with other anti-VEGFs who have had complications might have gone elsewhere. So that does not mean I do not have a complication. But of that I have seen, they're dreadful.
Yes, there are maybe some cases, but there has been a large trial, 21 centers, big centers. They've done multiple, 2,000 odd injections.
No, what I'm trying to say, it's we've seen side effects with every anti-VEGF that we've used, including Vabysmo, Eylea.
Yeah, we're not saying it is zero.
Yeah, but the occlusive vasculitis cases that we've seen with Pagenex, it's very, very scary. And I've seen about 7. And if you see those cases, you shiver. So it prevents you from using that molecule unless, as you said, the patient themselves ask for it. There are patients who have taken it elsewhere and they would say, no, I would like.
I have a few patients who have been asking for it repeatedly. This doctor got 29, and there are many others who got more than 10, actually.
Yeah, thank you, sir. Actually, move on to the next presentation.
Ashish wanted to, he's been standing. One quick question. Yeah.
This update. Can it just prevent such adverse reaction?
No, I don't think it is necessary because we cannot predict. Some people, if they get, then they need to be treated, not before.
Okay. Thank you.
Not before 10 weeks.
Yeah, there is no ad. Now we move on to the next presentation by Dr. Urmil Shah. When to stop.
So, good afternoon. Thank you to Team VRAG. And I would like to acknowledge the inputs of Dr. Kushal Deliwala and Dr. Mudit Bansal for managing this case. So I'll start straight off. It's a 60-year-old male, came to me in 2022, dimness in vision. The OCT and the fundus photo show findings of PCV. So it was a treatment-naive case, left eye being normal, was given 3 Eylea injections monthly. Vision is now 6/9. And then he keeps on following up. At this point, after the 3 loading dose, 1 year, he's stable, no repeat injection done. 2 years follow-up, no repeat injection done. And in 24, he develops a REG-RD. 2 years after the 3 loading doses. Undergoes a belt buckle vitrectomy with C3F8 and then followed by a cataract surgery. 6 months afterwards also, the OCT is stable, vision is 6/12, there's no recurrence of the PCV or no repeat injections. Now in 25, more than 3 years after the 3 loading doses, he complains of DV. There's now a serous PED. There's no hemorrhage. There's recurrence of fluid. Again, he undergoes 3 monthly doses of Eylea. A little bit better, but still not completely dry. So now 2 more injections as a bi-monthly treatment given. At 5 weeks, in fact, the fluid is now persisting. It's a vitrectomized eye. The fluid keeps coming back. I told the patient that we should probably get an ICG done, but he has some drug allergies, so he was very apprehensive to get any intravenous investigation done. So now I give the patient his first Pagenex. 1 month post Pagenex, I still see that there is persistence of the BV and the pachy vessels. now he undergoes the second Pagenix 1 month after the first one. 2 months after, so 1 more month after the second Pagenix, the SRF disappears. Vision is 6/12, but there is persistence of the pachyvessels, the BVM. I wanted to do a PDT, but I was told that there is no PDT machine available. So I just tell the patient, let's wait and watch. We given 2 Pagenix. And then he comes back with this 15 days later, that is about 1.5 months after the second Pagenix. There's a large bleed. Vision comes to 6/60, multiple PEDs. So he undergoes gas tamponade with the first dose of Vabysmo. At 1 month post Vabysmo is a little bit better, 6/18 vision, and now he undergoes an injection Ozurdex implant. So that is, now I give the Ozurdex implant, and 7 days after the Ozurdex I give the second Vabysmo. So this is probably about a month after the second Vabysmo. Vision is back to 6/12. The PED has resolved, the fluid has resolved, the hemorrhage is resolving. He undergoes the third loading dose of Vabysmo. So this is in March 26, the third dose. Next what? He's planning to go to the US in 26. So I said, we'll just space out the injections and give it to you at treat and extend regime. And when you come back, we'll continue with the treat and extend regime. So I went through literature. Obviously, there are reports of Dex implant being used as an adjuvant, as a monotherapy also for PCVs, and then for faricimab for giving a better efficacy in PCV compared to the aflibercept molecule. This is what actually I wanted to ask the panel, the seniors in the audience. This was like couple of questions that where did we go wrong? That should it been a treat and extend right from the start, that I gave 3 loading doses and keep on giving as a treat and extend, because for almost 2.5 years he was stable. So what was the approach I should have adopted then? Now obviously I'm going for a treat and extend approach. So would anyone have done differently in my place? So, and then the second point, that where does Dex fit in? Well, like, where do people fit in Dex in their treatment regime of PCV? Like, when would anyone want to put in a Dex? And if we give a Dex, when do we repeat it?
I personally haven't used Dex in a PCV case so far.
But sir, this patient was given 5 Ilias, 2 Pagenix, 1 Vabysmo, and then after the Dex and the second Vabysmo is settled down.
Well, it might sometimes, previously there have been reports where people treated PCVs with oral steroids also, along with anti-VEGF. So maybe steroid has a role, but it's just a one-off case, so we don't know. I think the best possible treatment in such cases would be to do PDT.
But there is no PDT available. I asked the Novartis guy, he said we stopped it after COVID. There's no PDT available.
Yeah, and if it's extrafoveal, you could just do a thermal laser.
That was my third part question. And if since there is no PDT available, does ICG have a role today in Octa? Should we do an ICG if there is Octa available and there's no PDT available? Should we still insist on an ICG?
Can detect better PCVs.
But what do you want?
Sir, this is just for the PGs, the fellows.
That you can do simple OCT also. PCV, you can diagnose it even by simple OCT. There is an OCT classification of PCV. You don't need an Octa or you don't need an ICG. Right? So if you are thinking for that purpose, I think they should master the OCT findings of PCV. They can easily diagnose it by simple OCT.
So the concept,
laser photocoagulation.
You want ICG guided photocoagulation.
Yeah. So basically for the photocoagulation, so we need ICG.
But that would be particularly if the lesions are very close to the fovea. If it is extrafoveal, you don't need any OCT guided. It's easily seen.
So
and there are clinical features, imaging features even on fluorescein angiography. If it's an extrafoveal polyp, even simple angiography gives you very classical pictures saying that there is a polyp here, and you could just laser that out. And clinically also, you do a slit lamp biomicroscopy with a contact lens, you can actually see the orange lesions very nicely. And that's how you can do your laser with a contact lens.
So consensus is no PDT needed, no PDT.
No, PDT would be definitely an option, but it's not available. That's
so
a problem.
No ICG also needed then. No ICG.
Personally, I don't think.
And Dex, what about Dex? This way, should I repeat it after 3 months? Dex? So the articles that I quoted definitely says that they've actually found elevated CRP levels in the aqueous humor of patients with PCV. So they are actually saying that they have done a meta-analysis of peribulbar steroid, oral steroid, intraocular steroid, triamcinolone, and DEX, and they said everything works, even as monotherapy.
Coming to the DEX, role of DEX with anti-VEGF. Actually, I had a similar case. The etiology was different. I had a ruptured macroaneurysm where there was a huge amount of SMD with submacular hemorrhage. I gave an anti-VEGF. After 20 days of anti-VEGF, the blood was resolving, but the SRF increased. The SMD was more.
Same as mine.
Yes. Then I injected DEX. I had a similar result, and it was flat for a longer time. So maybe the amount of inflammation may be more to tackle by only anti-VEGF. We need an extra steroid supplement.
And the last, this I wanted a consensus, like from everyone, that if you have to start a drug and a treatment, you would put it the drug of choice. Like we are spoiled for choices now. What would be the drug of choice? Aflibercept.
And I think maybe
So basically, कुछ गलत नहीं किया, I did the right thing. Okay.
One quick comment from my side. So regarding the steroids, I think Aditya was one of the authors of the papers where they had done a supplementary oral steroids in PCV. So probably if you would have been there, you would have given good inputs. Now coming to the point of Octa, I still feel that PCV is not a good disease to diagnose on Octa, because for Octa you need a certain amount of threshold of the flow. So polyps are usually low flow lesions. So usually you don't get those things very clearly, the BNNs and all those things like we see in the CNVs. So again, you always have to opt for the OCT guided by what has been described by Jemmy Chung and the group. And if we talk about right now for the PDT's current status, probably consider to talk to Dr. George at Arvind. He is somehow doing it, and probably it takes, I think, a month of a time to procure the PDTs. Of late, they have started.
So they've started giving it. Okay, thank you. And since everyone said earlier, the paper said that you need at least 4 Vabysmo injections to get a dry macula in a PCV after giving Eylea injections.
We move on to the next presentation. Dr. Rekha Singhal, empowering frontline workers in ROP screening with scalable offline AI. Interim evaluation of Medeos HI ROP AI.
Good afternoon, everyone. So my topic is empowering frontline workers in ROP screening with scalable offline AI and interim evaluation of Medeos ROP AI. So we have nearly 35 lakh babies who are born too soon every year, and we have 250 IROP members who can screen and grade these ROP images. And AI can help in bridging this gap, which can be used by the non-specialist, is available at 1/10 the price of the imported devices, helps in accurate, reliable detection of referable ROP and the plus disease, and can create an instant diagnosis to enable a timely treatment. So our research question was, how accurately does the Medeos ROP AI detect the ROP across different severity stages and imaging systems? Does AI support improve the diagnostic performance of a technician with a varying experience levels? And what is the agreement between the AI-assisted and a standalone technician diagnosis compared to the reference standard? So all the babies who had a gestation age of less than 34 weeks or a birth weight of less than 2,000 grams were screened, and the complete image set was taken with the different fundus camera like Redcam Shuttle, Redcam 3 or Forest Neo. The babies who had previously treated ROP or are having any media opacity, precluding the view of the disc or incomplete image set, were excluded. So images were analyzed and were uploaded to the label box, and the grading was done by the 2 ophthalmologists with experience of more than 10 years in ROP using the ICROP3 classification for the image quality and the ROP severity. And if there was a discrepancy, it was resolved by a senior ROP specialist with experience of more than 15 years. And the results were divided into 3 parts: type 1 ROP, type 2 ROP, or mild ROP. So this is the ROP AI workflow where the images were uploaded, they were pre-processed, and then the filtering was done. And the 2 criteria were seen, whether the plus disease was present or not, or the ROP detection is there or not. And depending upon whether both are present, then the urgent referral is indicated. If one of them is present, then non-urgent referral, and else it has to be followed. So the technicians did the grading in the label box similarly without AI assistance and with the AI assistance for image quality and the ROP severity. So in the interim results, we enrolled almost 654 eyes of 327 infants, and there was an agreement of no ROP or ROP of 0.88 kappa between the specialist 1 and specialist 2. So this is the interim result of technicians. So we can see the technicians without the IOP, without the AI, the sensitivity was around 83.9% and it increased to 97.06% with the AI. And the standalone AI had a sensitivity of around 96.55%. So the offline AI demonstrated excellent sensitivity of 96.55% and a high specificity of 93.9%, ensuring a reliable detection of ROP. Importantly, AI assistance significantly improved the performance of level 1 technician, increasing the sensitivity from 83.9% to 97%, particularly in detecting the mild ROP cases. So hence, the AI helps in increasing the sensitivity and specificity, ensuring the reliable detection of ROP. Offline Mediosi HI ROP program is a practical for low resource settings. This is the first side-by-side comparison of technician performance with and without AI, and it helps in boosting the accuracy of early career level 1 technicians, especially for detecting mild cases and type 2 diseases. Thank you.
Thanks, Dr. Rekha. So we can still know that AI may replace technicians in the future.
It will help, sir, because you will need technician to take the images, at least someone to take the images, and it will help in grading and help in not missing out any of the treatable ROP. And it will replace in the future.
It will replace in the future. Input, sir, what AI and ROP?
And with AI.
This is fair. Data.
Technical ROP aren't it up. So keep the kind of it is pretty there. It's uniquely done by the MS, not it's a implementation
technician.
On MS, I have a very cheap treatment device since there is spec. And second, it was space to the mouse with the but even if that are in depth. And the theory will get up drawn. But this baby needs some correct. Right? This can bring up dynamic of the number we will get the fire best out exam.
So the sensitivity is around 97%. What about those 3% medico-legally?
What's in me? Yeah.
So that
you ignore. Yes, less than the.
Can you bring the slide, please?
Months.
Here, the 3% loss which was there was the false negative was a one case with a stage 1 in zone 3. So the AI has helped in detecting all the cases who had the treatable ROP. So that 0.3% is only a baby who had stage 1 in zone 3 with AI. In this case,
even a single case of ROP, I think it matters. No.
No.
But other honest like it in like taking what 10 5 6 7 18 what but it's not it Frank this guy was speed one fish but not
even retina surgeons must
like it's not a big issue. It's not a
treatable ROP.
That is lenient. You cannot stop it, but you can also just get one exam.
You need.
Sir,
thank you.
Yes.
Thank you, doctor.
Just the question which you asked, sir, whether they are going to replace the technician or not. Actually, we are also doing the similar thing for diabetic retinopathy. What happens if the images are not taken properly? There's no meaning of AI. So technicians definitely has to be there, proper trained technicians, or as sir told, if nurses are going to take the images, if images are proper, then only AI is going to help us. Because we are having some portable fundus cameras which are having its own AI, but it is not detecting diabetic retinopathy so many times because images are not proper. So the same problem is there. Technicians won't be replaced. Maybe doctors may be replaced.
We need even better technicians now.
Definitely.
That will
Yes,
help level 1 technician. Right now, the problem is we need level 3 technicians in the ground. There with the AI level 1 technician, here we have level 1 technician who can just take the images. Okay, and the AI will take the images according to whether they are gradable or not. If it is not gradable, press out.
Yeah, thank you, Dr. Rekha. Now we move on to the next presentation by Dr. Shilpi Shah. Late reactivation of ROP treated with anti-VEGF. One more ROPs.
Good afternoon, everybody. So I'll be sharing few interesting cases of late reactivation of ROP treated with anti-VEGF. So according to the ICROP 3, reactivation is defined as appearance of new lines or ridges, new extraretinal neovascularization or plus disease after original regression of the disease. Now, highest chances of reactivation are between 8 to 16 weeks, depending on what injection has been used. Ranibizumab shows earlier recurrence compared to bevacizumab. And therefore, it is recommended that all infants treated with anti-VEGF must be followed at least until PMA 65 weeks. Now, the highest chances of reactivation are after anti-VEGF treatment because it only temporarily reduces the neovascularization, but it does not address the peripheral avascular retina as addressed by the laser. So less frequently reactivation has been documented after spontaneous regression of the type 2 ROP, or sometimes very rarely after adequately done laser. So here is the first case of a very tiny, extreme premature infant born at just 24-week gestational age with birth weight almost 600 grams and had an ICU stay of almost more than 4 months and prolonged oxygen requirement, all possible risk factors for aggressive ROP. So this infant was diagnosed with aggressive ROP in zone 1, and the first treatment was given with Avastin at PMA 32 weeks. The disease regressed only to come back 6 weeks later when the infant was still on oxygen in the NICU, and a second Avastin was given since the reactivation was still at the edge of zone 1. Now this picture here shows the 2 weeks later. You can see the disease has again resolved after second dose of Avastin, but the vessels are still just at the edge of zone 1. So this is the time we started to observe the baby with a close follow-up. And 3 months later, at almost PMA 50 weeks, the disease came back with a ridge in the zone 2 posterior with new vessels. At that time, confluent laser was done all the way up to the aura, as shown in the picture here, and the disease regressed nicely, and the baby was kept under the follow-up. At 1 year, the vision was fine. There was no myopia. On the Cardiff card, the vision was almost 6/9, no strabismus. Only at 1.5 years of age, 18 months, on a routine checkup, you can see on the top photo here, the green arrow shows a tiny blood over the laser bed. Now, this baby was sent for angiography, and you can see with the blue arrows in the bottom corner here that there is a leaking new vessels at the edge of vascular and avascular retina, and also in the right eye there is some leaking new vessels. So the laser was augmented here, and the disease regressed. At the last follow-up at 3.5 years, the vision was 6/9 with mild astigmatism and stable retina. Here is another interesting case of aggressive ROP where the baby had rush disease, non-dilating pupils with new vessels at iris. Avastin was given at PMA 36 weeks, and the disease regressed nicely, and the vessels progressed forward almost until zone 3. So at PMA 48 weeks, there was a PAR in zone 3. The laser option was discussed. The parents preferred to observe. And so we continued to see the baby at 66 weeks. This retina was stable with mild PAR. And this baby continued to come to us for regular follow-up twice in a week. And at 8.5 years, when the unaided vision was 6/6, stable retina with only white without pressure documented. This is the mid-periphery. As we can say, you can see the posterior pole and mid periphery in the right eye looks absolutely normal. Only to see the far periphery, you can see that there are tiny blood spots appearing just at the edge of before the white without pressure. And we did an oral angiography for this patient. And on the top, you can see the leaking new vessels in the right eye at the temporal periphery. The left eye is showing peripheral avascular retina as shown by those stars. And another third case was similar. He had a hybrid aggressive ROP in zone 2 posterior, treated with single Avastin at 36 weeks, and the patient regressed nicely with PAR in zone 3 until PMS 60 weeks. And this baby was lost to follow-up in the COVID period and only to reappear at the age of 5 years. When his vision was 6/12, there was only mild with the rule astigmatism, but the fundus, if you had seen carefully, this case was published in IJO. You can see in the top slide there, the right eye shows hemangioma-like lesions at the junction of vascular and avascular retina, which were the new vessels. Again, this child had peripheral laser done, and these regressed very nicely. At the last follow-up, the BCVA was 6.6. So the late reactivation, the challenges here are delayed timeline. It can happen 50 to 70 weeks PMA and beyond. So in the PAR potentially is ischemic for years, and it serves as a substrate for late recurrences, holes, and retinal detachment. Atypical morphology of this very late reactivation, and it can be very subtle as in some patients. Also, the babies are larger when they are toddler, and it is very difficult to check the temporal zone 3 peripheries. And also the logistic of frequent visits for years for parents to bring them, and also the financial. So what should be the management strategies? Extended monitoring till the vessels reach zone 3 and beyond, or at least full maturation. FFA can be a useful guide for those subtle reactivation, leakage, and for the peripheral ischemia. Laser is the definitive treatment for reactivation and PAR. And counseling with the family should be done in detail at the very outset when you treat initially with the anti-VEGF, that this is a long road ahead. So remember, anti-VEGF is a bridge and not always a destination. Vigilant long-term follow-up is the only safeguard against late onset vision loss in those babies. Thank you.
Yeah, thank you, Dr. Shilpi. So what you suggest, in cases of PAR, like whenever you see PAR, we should laser those cases?
Well, ideally, if there is a significant PAR, and if you think the babies won't be coming for regular follow-up, then it is safer to laser them, because there are so many case reports coming up of late retinal holes in those PAR area, and also late retinal detachment, late reactivation, even beyond 6, 7, 8 years.
So we don't treat all the cases of PAR.
It's entirely up to us, and also you have to discuss this with the family. When you leave PAR, you have to tell them that this is a potential that even at 10 or 12 years, your child is at a risk of losing the vision if it is not under a regular follow-up.
So we treat only those patients who are, we feel that they'll be losing to follow-up.
No, you do discuss this. I always discuss this. And if they are ready to bring the child for follow-up, they anyway do that for the refractive error and for the strabismus part. They do bring them at least 6 monthly. Till, as I said, this boy was absolutely asymptomatic, the 8-year boy. If he wasn't under the follow-up, he would have had either a vitreous hemorrhage or a late retinal detachment and lost the vision.
The scary thing was that one child was already lasered and he developed new vascularization. So the child was doing well.
That's right. That was a very, that was treated with twice with Avastin. When you treat second time with anti-VEGF, we are doing a research which is under the publication. When you inject second time with anti-VEGF, there are only 12% chance that retina would fully develop. More than 50% chance that it would end up with a PAR, and only 28% would also have a third reactivation, which happened in there, and then you have to laser.
Yeah, thank you, Dr. Shilpi.
Yeah, thank you.
So we move on to the last presentation. Dr. Dhwani Mehta, case report of occult macular dystrophy, a hidden cause of vision.
Good evening, everyone. Today I bring you a case where vision loss had no visible clues, or we thought so. 28-year-old male patient presented to us with complaint of gradually progressive blurring of vision in both eyes since 1 year. His visual acuity reduced from 6/9 to 6/24 over the span of 1 year. His near vision was N6. His color vision was both eye 4/21 plates. He had no significant systemic history. On examination, his anterior segment and posterior segment findings were within a normal limit. So clinically, we had reduced visual acuity but no visible lesion. And to rule out subclinical macular pathology, we did STOCT, which was essentially unremarkable. Given the presence of reduced visual acuity and color vision with normal macula, a neuroophthalmic opinion was taken. And they advised Humphrey Visual Field 30-2, which showed mild central scotoma in both eyes. To rule out any structural lesion in visual pathway, MRI brain with orbit was performed, which was within a normal limit. But as MRI only rules out structural lesion, but it cannot assess the function, to assess the optic nerve function, we proceeded with visual acute potential. And VP showed normal latency but reduced amplitude, suggesting that optic nerve conduction is absolutely fine, but there is a problem in impulses arising from the retina. So at this point, we had central scotoma, means either there is a problem in optic nerve conduction or structure, but normal OCT made us to think that there is a problem in optic nerve, but normal MRI and normal latency in VP ruled out that and made us to reconsider our localization and shift focus back to the macula. On closer inspection of OCT, we identify subtle disruption in the ellipsoid zone, a feature easily overlooked. So this subtle EZ disruption in the subfoveal area leads us to these differentials. So let's rule out them one by one. First is a toxic maculopathy. As this patient was not having any significant drug history, toxic maculopathy was ruled out. Post-inflammatory changes. This patient did not have any history of episodes of blurring of vision in past. So now we are left with a progressive cone dystrophy and occult macular dystrophy. Progressive cone dystrophy affects a cone of entire retina, causing reduced photopic responses in full-field ERG. While occult macular dystrophy is a localized cone dysfunction, causing reduction in impulses from the macular region only. So to differentiate between them, we did full-field ERG and multifocal ERG. And ERG cleared the picture because full-field ERG came normal, excluding progressive cone dystrophy and focal reduction in multifocal ERG pointed towards the localized macular pathology. So probable diagnosis of both eye occult macular dystrophy was made. And genetic testing confirmed the RP1L1 gene mutation, a definitive hallmark of occult macular dystrophy. So what I learned from this case is a normal looking fundus does not mean normal functioning retina. Functional tests are important when structural test does not give any clue. And when findings don't match, re-examine your investigation. So nothing in this case was hidden. We just needed to look at it differently. Thank you.
Yes, thanks, Dr. Dhoni. Interesting case. Anything, ma'am, would like to discuss? It was an interesting.
Thank you.
Very, yeah, very well presented.
It's
Yeah, it was a nice case.
yes, sir.
And to see so subtle things, right? The macula.
We just label it as amblyopia or whatever. It's like basically an.
Sir, I have one question. In this patient, the near vision was absolutely normal. He was having N6. So the defect is in the macular region, although there is a N6 vision. I read about it. The theory said that due to accommodation and parafoveal cones are working, so that might be the reason that his near vision is normal. But I could not find it satisfactory. So yeah.
And it's so easy to magnify.
Yeah.
That's right. It's easy to work around near vision rather
Yes,
than
ma'am.
What was the age of the patients?
28-year-old, sir.
So that may be one of the reasons because
Yes.
younger patients, some of the Thank you, Dr. Dhwani. I think we finished on time. It's about 4:30.
Awesome. Thank you, Navneet, and all the panelists. This is amazing. Absolutely sharp. 4:28. We have 2 minutes before time. Super. Super.
So thanks to all the panelists.
We'll just give us 5 minutes and we'll be announcing the best paper and the best poster.
Thank you, sir. Right. So very what feedback. Right. Yes. So we are going to float a feedback form. So everyone is requested to fill that form for feedback. So how was the conference and what all things are needed in future. So कोई नए सेशन के बारे में या नई कोई चीज के बारे में अगर किसी को अगर कोई सेशन चाहिए, you can always tell us in that feedback form. Yeah, please. Gujarat is not having.
Nobody has. We should all get together and have a center.
Bharat Rana, you
Yeah.
have to get it.
Bharat
Rana.
तभी यार
अपना आयरन में पाचा पड़े हैं तो क्या ये कठिन नहीं है
माता कह रहा हूँ जो बदल ऊपर आप पीछे चलो बताए
Good.
We are ready to announce the
But
prizes.
what you told is really good thing, sir. Actually, there's because
without so expensive.
Because
not going smart in the first thing I think it's really was
yes, definitely there should be like LASIK people, they are doing it. So they're making one laser center and everyone is sending cases there. So right now what we are spending for the things, like if we see for our optos it's around 1.5 crore. If we see for OCT latest one, they are so diagnostic center should be there for everyone. So for top notch basic one, like basic OCTs and all, anyone can get. But for top notch thing, they should we all should have one common center where we can invest and where we can actually earn from that. Otherwise, earning
is not a bad mistake. The faster the treatment.
Yes, it is sustainable. That is the right way. Yes. Yes. Because when I'm spending for this top-notch machines, in the end, at the end of year, when I'm spending again for the CMC and AMCs, I know like how much I am spending. So whether I'm earning from that or not, yes.
Right.
So that is the thing. That's why we should have a common center and we should have a consensus in every city like that. So, yes.
Just load that from P of Pan in Gujarat and every big city will have a center.
Definitely.
But why not? Why not?
Yeah. We are ready to announce the prizes.
Yes, sir.
So, poster nu chalu karu मैं क्या?
Nothing. You're not eating now.
Yeah, you know what? The best poster prize goes to Dr. Bhavik Panchal for bleb-like retinal detachment in aggressive ROP. The best prize in Uvea Session goes to Vishal Dedia for his cases on SIPs and SILs. I don't think any of the people are here at all. Vishal is left. And the best prize for surgical retina goes to Dr. Pathik for the amniotic plug. Oh, that's it. It goes great. Very deep. And the
Congratulations.
The best prize for interesting case in medical retina actually goes to Dhwani. Everybody for their cases and for the participation. Even selecting the papers was a challenge. And the input of the team made it all very easy. And we're just hoping to get better. So give us all your feedback, positive, negative. Let it come.
Special thanks to Kumar sir for always being a mentor and guiding us for this conference. And I leave it up to the two main pillars of this conference. I think they deserve a big round of applause, huge applause. And everything is because of them. They've literally physically worked hard for it, not just mentally. So Kushal and Parth.
So now we would like to conclude our conference with thanking. Actually, we would like to thank all of you for coming here, for spending time and actually trusting us and making this conference successful. So we'll thank all the delegates.
Next, we would like to thank all the sponsors who have participated with us and making this conference a very grand success.
We would like to thank Friends AV for actually getting us really good AV, and it's really remarkable.
And the backbone of our conference has been from the day one, our tech team, the Adi Tech. So whatever communications you people had on behalf of them, Deepak Bhai, Himali Ben, they have all been there. Even at night where we tried to have certain concerns, they would immediately give us the feedbacks, and the tech part has also been looked after very smoothly. So thank you very much.
And we would like to thank LVP staff also. So this wonderful venue is there and their hospitality is really great. Thank you. Thank you. Yes, AV. And now we would like to have national anthem.
Janagana Athivaya Jayan Bharata Bhagya Vidhana Punjab Singh Gujarat Maratha Havira Uttara Puringa Inja Himachal Yamuna Ganga Purishada Chamati Parhamda Tava Shubhana me jage, Tava Shubhana Ashisha mage, Yane Tava Jaya Dvai Havagya, Sana Dainam Sanan Avdan Anaya Jaya Yadam Kelvin Hada,
Bharat Mata ki.
Nice one. Very excellent.